Hey, Chas.
Hi, everyone. Yes.
Okay.
Hi, Shem. Hi, Ronnie, Sunil,
Hi.
Chin Rong. Yes, Tanuj, Swati, of course. Yeah.
Hello.
Hi,
Chad, a
but
very original pairing of the surgical scrubs with a suit.
I have become one of those guys now, as my wife commented.
Can you just speak
So
to
we are
Dr.
live.
Wong? Yeah. So, welcome all of you all to this global mixed webinar on minimally invasive glaucoma surgery. We have eminent panel throughout the globe from US, from Singapore, from Hong Kong, the speakers, and we have the esteemed panelists from our own country who are high volume MIGS surgeons, and they're going to share their views after each talk. And before wasting much time, I just would like to introduce the chairman of a scientific committee of All India Ophthalmological Society, which is Dr. Namrata Sharma. Welcome, ma'am. I welcome all the speakers
Thank you.
and the panelists for this esteemed webinar. And so Dr. Namrata Sharma, she is the chairman scientific committee of All India Ophthalmological Society. She doesn't need any introduction. She's got huge number of publications. She's got more than 600 publications. She is heading the Department of Cornea in RP Center. She's also the chairman of All India Ophthalmological Society of Scientific Committee, president of the Corneal Society of India. She's a regional secretary of APU. She has 2 patents in her name, that is Natasol and Natamatrix. She's the first Indian to be inducted as a director at large in the international member in the Corneal Society of International. She's elected as a member of the Afro-Asian Council of Ophthalmology. She's got huge number of list of national and international awards. She has authored more than 18 books. She has been the principal investigator for many trials, RCTs. So this is just a short CV, what I'm explaining about her, but she is a very dynamic lady of All India Ophthalmological Society who has taken AIS at great heights. Madam, few words from your side before we proceed for this webinar.
Thank you for that kind introduction and very elaborate introduction. For me, it is a great pleasure, and I think for All India Ophthalmological Society, it is an honor to have speakers on a very important subject, which is MIGS, and which is so very popular from 6 other or 5 other countries apart from India. Thank you very much for being here. And of course, we have our esteemed panelists and experts from India as well as speakers. So I'm sure we are going to be having great pearls from this webinar, and especially for the glaucoma specialists who want to graduate into MIGS, and all those who are actually doing MIGS, I'm sure are going to benefit in taking it further forwards. So thank you, Amit, for organizing this. I know it is a very huge task to get everybody from different time zones here, and that too at 7:30 p.m. And thank you, all of you, for your time and for your contributions today. Over to you, Amit.
Thank you, ma'am. So for our panelists and the speakers, minimally invasive glaucoma surgery is picking up in India. We have 2 popular mixed procedure in India, that is Bang and GAT, which is practiced at high volume in our country because of the economic situation which is there for these 2 procedures. But a lot of young surgeons and the experienced glaucoma specialists and even cataract surgeons are picking up the mixed procedure. So this webinar is going to basically cater not only the glaucoma surgeons, but also the comprehensive ophthalmologists who wants to get exposed to mix and who want to refine their mix skills. So this webinar is going to basically benefit these people also. Now going ahead with the same thing, introduction of our speakers. I have to introduce myself because this is going to be a global webinar, and just so this is myself, Dr. Amit Porwal. I'm going to moderate this whole session. I just, yeah. Sunil, can you help me with this?
So you can just put the play and then start scrolling downwards. You can just click on the screen and start moving downwards. Yes.
Yeah. So I'm Dr. Amit Porwal. I'm graduated from Jain Medical College, Belgaum, and I've done my fellowship from Arvind Hospital, Coimbatore. I'm a teacher and trainer in glaucoma and cataract surgery, and have been awarded with the ISKRS Young Achiever Award, iBeach Film Festival, the IRSI Gold Medal Award, South India's Got Talent Award, and won the best physical poster in AIOC. I'm on the editorial board of Journal. I was also the section editor. I've delivered more than 650 talks. I've invited guest faculty and have performed live surgeries. I have 30 publications in index and non-index journals and 8 chapters in books. A past member of AIS, ARC Central Zone, and the Central Zone Executive Member of Glaucoma Society of India. Presently holding the position of Member Scientific Committee of All India Ophthalmological Society and Chairman Scientific Committee of International Society of Manual Small Incision Cataract Surgery, MP chapter, and heading the Department of Glaucoma in Choitram Nethralaya, Indore. Coming to our first panelist, Dr. Tanuj Dada. He's a professor of ophthalmology and head of glaucoma services at RP Center of Ophthalmic Sciences in All India Institute of Medical Science. He is the board of governors and board of director of APO. He's the executive board of International Society for Glaucoma Surgery. He's a scientific program committee of WOC, WGC, APO, APGC, associate editor journal of glaucoma, editorial board, American Journal of Ophthalmology, and he has over 350 index publication. And he was one who was the pioneer of Migs and who introduced us to Migs in our country. Coming to Dr. Sunita Dubey, she is a medical director and director of glaucoma services at Shroff Charity Eye Hospital. She has done a glaucoma fellowship from Wills Hospital, Philadelphia. She has got extensive experience in management of pediatric, refractory, secondary glaucoma, and a special interest in GDD and in Migs. She has trained fellows and residents since past 2 decades and has more than 150 publications and book chapters. She is member of the Glaucoma Task Force, Ministry of Health and Family Welfare. She is nominated as honorary professor by Indian Medical Association in 2017. She was a past treasurer of Glaucoma Society of India. She's received several prestigious awards in AIOS, IPGS, DOS, ACOIN, and she's the reviewer of peer-reviewed journals, including JOG, BMJ, BGO, and she's the voluntary faculty for Orbis International. Coming to Dr. Ronnie George, he's the director of glaucoma services at Shankar Nethralaya, Chennai, research director, Vision Foundation, member of the editorial board, and a past secretary of Glaucoma Society of India. He's got numerous publications and chapters written in the books of glaucoma. Coming to Dr. Ganesh Raman, he is a friend of mine who did his fellowship from glaucoma from Arvind Hospital, Coimbatore. He joined the Arvind Hospital, Coimbatore as a consultant in glaucoma and now is heading the department and almost trains 4 fellows every year. He's an extensive experience in glaucoma surgery and offers canaloplasty, NPDS, GAT, and other angular mix and patchless glaucoma drainage implant surgery to glaucoma patients. He has, to his credit, about 40 publications and chapters in various textbooks of ophthalmology. He was the South Zone Glaucoma India Education Program Coordinator in 2016 and 18, has conducted several glaucoma education programs. He was the secretary of Coimbatore Society of Ophthalmic Surgeons in the past. Welcome, Dr. Ganesh. We have Dr. Devendra Maheshwari, a high-volume mixed surgeon in Arvind Eye Care System. He did his fellowship from Tirunelveli Arvind Eye Hospital, short-term fellowship from Bascom Palmer Eye Institute, Miami. He has done observership at various places in US. The list is enormous. He's presented papers and posters in national and international conferences, has more than 50 publications, presently associated with a number of national and international studies and research going on. Best Glaucoma Paper Award was won by him in TNOA conference in 22 and 23. And his area of interest is Migs in Asian population, especially the Migs in angle closure glaucoma, along with emerging goniotomy procedures. Now, I welcome all the panelists, and now I would like to introduce our first speaker, Dr. Shamira Pereira. Dr. Shamira Pereira is a senior consultant ophthalmologist, Glaucoma Service, Singapore National Eye Institute, National Eye Center. He's the head of cataract research, Singapore Eye Research Institute, associate professor, Duke, NUS Graduate Medical School, deputy director of MedTech Office, SingHealth, program director of SNEC Eye Residency, clinical director of complex anterior segment surgery, SNEC. His CV is very enormous, but what I would like to mention about him is he has won quite a few awards. He's got patents in his name. He's involved in new innovations and researches. He has got several grants approved. He also gives grant to different innovations. He works closely to commercialize devices in glaucoma and cataract surgery. He's won the Golden Apple Award, winning Golden Apple Award. That is a free app module to teach and test cataract surgery. He is one of the 100 influential ophthalmologists in the APAC region, and he was conferred the AO and APO Achievement Award and also the Distinguished Service Awards. Welcome, Dr. Shamira Pereira, and all yours. I welcome all the panelists, and we start with the first talk.
Okay, thank you very much for the very kind introduction, Amit. And I must say thank you to Namrata and Tanuj for getting me involved in all this. So if you can hear me and see my screen, I will make a start.
Yeah, we can hear you and see your screen.
Thank you very much. So my talk is basically about mastering the skills for the basics for Migs, which is gonioscopy. And although it's been given short shrift in terms of its importance, I will try to convince you that learning this universal skill will help you master gonioscopy and the future of Migs and other surgeries as well. So these are my financial disclosures, some of which are relevant to today's presentation today. And I'll be explaining how it's important to make sure that you use gonioscopy on an everyday basis because it uses your non-dominant hand. And this will help you every day with your natural phaco surgeries as well. It's important to keep a good view, and we know that without a good view, you will not be able to get your stents in the right position. And it requires a really gentle touch. And it's also important to maintain your anterior chamber because often when you start pressing with your device, with your gonioscope, it's not a good view. Whilst several of the skills I'm going to teach you today are transferable, I'll be going into a bit of detail about how the view needed for each particular Migs is slightly different, and I'll show you how you can get the best out of your views to get the best insertions possible. Now, also, this will help you with other surgeries like goniosynochilasis, iDose, and maybe even the Zen 45, which are not, typically termed of as the TM Migs, which is going to be the mainstay of this particular talk. But I'll show you how these skills can be used elsewhere as well. Now, let's move on to the basics. So it's important to get a clean piece of kit. Often when these devices like your gonioscope have been washed several times, you end up with water droplets on them and they can leave stains. So it's important to sometimes clean the gonioscope or get a disposable prism which doesn't have any of these problems. Remove the chance of getting interface blood between your cornea and your gonioscope by removing the incisions further corneally. This will prevent some of the blood getting in the way. It's always a pain when this happens, but again, if you prepare the situation better, then you can avoid some of these problems. Be also prepared to move to a different site. Traditionally, we will do a temporal phaco and insert our devices or do our surgery nasally, because that's often where the collector channels are. But in this particular situation, if you can't get it in and you've lost your view, that it's important to be able to move to a superior position or even across the nose. Okay, so I think it's important to be flexible with your surgeries. And remember, the first shot is your best shot. So prepare yourself well to get it in the first instance and only resort to these other situations if that cannot be done. Let's move on to some surgeries. Now, this is a video of actually goniosynechilitis, but what I'm going to be concentrating on actually is the views that you're getting. So this is with a Swan-Jacobs lens, and you can see it's a very clear view that a needle is being used to peel down the PAS. So you can see there's no striae on the cornea. And this is because this is a very experienced surgeon, and they're able to hold the gonioscope very gently. This is a different scope. This is, again, Swan-Jacobs, but a different type. And again, the gonioscopy is done so you get clear view, no striae present. Okay, again, here with this surgery, you can get a very clear view of the angle. There's not much reflections. There's not much interface blood at all. It's very, very clear view. And you're able to perform the goniosynechilitis very, very easily. Next, now this is what we use as a Mori lens. And you can see me performing a sweep procedure, tap and sweep procedure, where you can see that we're pushing the PS away. And it's important to make sure that you've got the most appropriate view for your surgery. Let's move on to some of the other situations. So this is out with Migs, which is the main aim of this seminar, but I'm going to show you how Migs can be used in some unusual situations. Like, for example, this one, you can see the PAS automatically being present in this position here. I'm still going for a hydrus in the TM, and I can put this in the area of clarity. It obviously goes behind the area of PS on the left of the screen, and I'm tapping into position with the injector. But now I'm using the injector itself to go and peel off the PS, thereby revealing the device in the canal. So I'm just showing you now how you can use your gonioscopy with a good view to not only put in the device, but also to perform other procedures, like in this case, a GSL, to remove some of the PAS. This, of course, is a non-standard indication for this, and it's off-label use. This is a slide from a talk I gave recently about why it's important to learn the gonioscopic view and why it is particularly useful to put in devices into the canal. We've got the situation now, we have got the best teaching tools available, excellent gonioscopes, and more importantly, excellent surgical support from our mentors on the pharma scene. We have evolved injectors that are not just the first generation, but the second generation and even third generation to getting these devices in. And also, this is a useful pathway for learning other devices, for example, the iDose and even things like the iStent Infinite. And it's important to be able to stretch the limits of these even off-label uses when you're getting good insertions. So it just shows you that by learning a good technique of gonioscopy, you can utilize these skills further afield. This is some of the learning materials from Glaukos, and they have an excellent set where you can learn exactly what is 2 clock hours away when you insert these devices. Often we underestimate what exactly 2 clock hours away is, and here you're being shown it with artificial markers on the iris. And they even have prisms which are self-stabilizing to get the best views. I think one of the most important things about gonioscopy is getting the right angulation on the eye. And when you've got two options of basically either being able to manipulate the scope or the patient, go for the patient. By manipulating the patient away from you more rather than the scope, your arms are not outstretched that much and you don't shake so much. So move the patient and not the scope. You need to be aiming for around about 35 degrees angle between the microscope and the eye. But of course, it depends on the type of surgery that you're performing. In this recent study, using the NIDEC GS1 gonioscope to look at the position of stents of the iStent, they found that only 14% were in perfectly in the TM. Now, if you include the ones that were in TM and SS, that number rises considerably to around about 70%. But of course, they're not perfect. So I think it's important as glaucoma surgeons to be able to go and put these stents in perfectly. And if they're not imperfect, go and do it again. Here's an example of some of the views that you might get from different prisms. So look at the Swan Jacobs, which is a glass prism and mirrored on the left, which lets in more light, versus the eye prism, which is plastic, but gives you a slightly different kind of view. So they are different, and it's important to be able to realize this when you're utilizing these things. Here's an example of a gonioscopic view when I'm putting in a G2W. And you can see, again, very little striae on the screen. You press in, put the stent in the right position, move across 2 clock hours, and then again go for a separate site, hopefully targeting a different set of collector channels. And again, press in, and again, the stent is put in the TM. And you can actually see when you put the pressure down low in the eye, there's efflux of blood from the canal into the anterior chamber. You should put pressure up, this blood goes away. So example of a good insertion, and you know that there's going to be fluid draining. You can also check on the other side, of course, for a fluid wave, but that's a separate story. Here's another example of a G2W going in, but I think the key thing is looking at the view. I think it's very important to hold the gonioscope very gently. And I hold it actually resting on 2 fingers, and the thumb is hardly holding it at all. When I hold the gonioscope for my resident doing it, they almost always get it in. But when they transition to using the gonioscope and bimanually putting the device in with the other hand, that's when things get a bit more difficult. It's important to plan your approach with certain devices like the Hydros and get that on-fast view. So here, you have to get that equilateral triangle with 120 degrees between your side port, your insertion, and the point of injection of the device. If you're not quite right, you can get too acute an insertion and it might not go in properly. It's important also to keep the eye very flat. You can see the very flat insertion on the left-hand side of the picture. Look at the one in the middle. It's very angulated. Still possible, but difficult because your view is not normalized. And I think it's important to rotate the head and the microscope in the right direction to get the view ideal. OVD coupling agent is not essential. I personally don't like it that much because it can sometimes get incorporated with blood and obscure your view. But the important thing is to get an increased magnification to fill your view. The view that you see on the left is the best on-fast view that you can get. You can see on the right, it's a bit more top-down. It's difficult to insert. Also, getting your anterior chamber pressure is very important. Too low, and you may get a lot of blood in the canal, but the striae might obscure your view. If it's too high, you lose the striae, but you might flatten your canal, getting it difficult to insert. I'll give you a few tips about how to make your situation easier to make sure that you get that good efflux of blood into Schlemm's canal. And one thing is to massage the sclera so that you're pushing blood into Schlemm's canal so you can get a good red, juicy canal to inject into. Here's some views of something that we call the water gonio on the bottom half of the screen. You can see there's no gonioscope here. There's in fact just the prism that's formed between using your hand and the blood, the fluid, to enable a good view of the angle. In the top screen, there's a usual Swan-Jacobs gonio lens, but here is what we call water gonio, where you create a prism by the triangle of fluid, and you can get a good view of the angle. I use this for checking of the stents that they're in the right position. You can see that here I'm able to put a irrigation aspiration to go and see the device neatly in the canal there. Here's an example of a KDB being put in, and you see it's a little bit underinflated, see a few striae on the cornea, but nevertheless we're enabling a good view, and the KDB goes in and it slices through like a knife through butter across the TM, giving you essentially a histological section of the TM that can be peeled away. And you can see the KDB putting in the opposite direction again. Of course, you'll be careful with this that you don't put too much pressure on the eye. And that's one of the big problems with the KDB, because the view does tend to go, especially when you get a massive blood efflux into the canal, the view does tend to be compromised somewhat. In another of the surgeries like this, which is a ABIC, it's important to get on fast again because you're inserting something into the canal itself. And here I'm just incising to get the catheter in, but I think this is one of the key situations where you need to have a great view, like with the Hydrus. Some cases like the iStent, it can be more forgiving and you can get a good insertion nevertheless. But here, because you want to get a very flat insertion and you want the cannula going all the way around, you need to have that good flat angulation on the eye. Once the stent is inserted, you can see it pulling out and injecting fluid in, and it comes out completely here. And you can see the expander canal in this picture right now. In conclusion, I think it's very important to practice whenever you get the chance. So when you have your last case on your phaco list, just put on the gonio and have a look at the angle. It gets you used to the structures and the view as well. Be flexible when you're performing gonioscopy and learn to live with uncertainty. Nothing is perfect. The view is never going to be perfect, especially if you're doing it after a phaco. The view can be compromised. There can be blood in the angle and in the anterior chamber. A good view precedes a good insertion, and it behoves us glaucoma surgeons to do the best for our patients. So if the stents aren't in the right position, take it out and do it again. Get it perfect. So I'll leave you with that. Best of luck with your surgery. Practice makes perfect. Thank you very much.
Thank you, Dr. Shabira, for this nice presentation. You covered up everything very nicely, and one new terminology, what we heard is the water gonio. But I feel water gonio should be tried only after you've performed more than 1,000 mixed procedure, because it is not so easy to do a water gonio. You are an experienced surgeon, you can do that. But for people who are just want to learn intraoperative gonioscopy, there are a lot of other important tips which we have to discuss. So I request Dr. Tanuj, can you just share a few important tips, what has to be avoided and what has to be done while doing intraoperative gonioscopy?
Thank you, Shamira, and thank you, Amit. So I think first, this water gonioscopy is quite innovative, and that is just for viewing the angle. That is not for operating on the angle. So just for beginners who don't have a gonioscope, you can view the angle structure, see what is an open angle and a closed angle. So it's a very nice thing advocated by Shamira. And regarding gonioscopy, I think for our residents, it is better to mark on the microscope what is actually the 35-degree angulation, because that is often erroneously, subjectively, people just tilt the microscope. So if you can have a mark of angulation, that is helpful. Second thing is regarding, of course, the tilt of the patient. And then it is good to put a cohesive viscoelastic on the cornea. And when you put in the gonioscope to view the angle structures, you start with a low magnification. And sometimes just for viewing the angle, you can indent from the opposite side with a blunt instrument. And then the angle becomes very clear if you are having difficulty in the initial cases. And for beginners, another trick is after you have viewed the angle structures, don't do any mix procedure. You just learn to go and touch the TM with any blunt instrument or a viscoelastic cannula. So you get a hang of actually manipulating the TM. And I think it is better to do some wet lab training and then shift on to live microscope training and then perform your mixed procedure. And I think with the current Swan Jacob and other disposable lenses, it has become quite well. And there's some recent advances like the gonio ready lenses where it's a hands-free, so that is fixed to the microscope. The gonioscope is on the eye, and both hands of the surgeon are free. So that is a recent advancement that has taken place. So those are few tips for beginners for intraoperative gonioscopy.
Yeah. So, Dr. Devendra, I would like to ask you how you teach your fellows how to learn intraoperative gonioscopy. We have conducted quite a few ICs on MIGS in India, and we have been propagating this talk of beginner's guide for intraoperative gonioscopy. So, I would like to know some few tips from your side regarding the incision, how to avoid the blood, how to avoid the wrinkles, what should be the position, which gonioscope is the best, because now we have disposable gonioscopes also, we have the autoclavable Swan Jacobs. So I personally feel it is not one size fits all. Every gonioscope, whether it is the ocular, the Catina, the Vogue, every gonioscope gives a different view. So Devin, over to you.
I think Tanush sir covered most of the topics. Most of the topics around this, how to do the intraoperative gonioscopy, and Dr. Samir has explained nicely. So few topics when you start this intraoperative gonioscopy, suppose the incision, what you're making for any mixed incision, it should be that all incisions should be the clear corneal. Apart from that, the point is missed, you have to keep your table little above. So reverse tendible position should be your table. So should the head above the heart. So you can not get the blood reflex. Regarding the gonioscopy, first of all, just practice with the hands free. That's I told. At the Catina having the hand free gonio. So that can be beginning to see the structure initial phase. Then you can go for the Swan Jacob. I personally feel Swan Jacob oculars give the nice magnification as well as the good stability once you have the good control on the left head. So, and regarding the instrument, you can take the spatula. I think this is a basic thing you can start. So do the gonioscopy and just touch the TM with the spatula. That should be the beginning for your MIGS. And I think at the end of the phacoemulsification, just you put the procedure, observe it, and control the marking. Marking is very essential. You mark correctly, the marking 30° and change the head position. Apart from that, when you're holding the lens, so sometimes most of the beginners, what they do, they hold the lens, but they not hold the center. Either go superior, either go inferior. So the lens should be exactly onto the 3 o'clock position. Then you can have the nice view of the angle, the in-first view. That's more essential.
So few take-home messages. To avoid the blood between the gonioscope and the cornea, place a clear corneal incision instead of a limbal incision. To avoid blood and the wrinkles and excessive pressure with your non-dominant hand, with which you're holding the gonioscope. For beginners, we can use the self-retaining disposable gonio lens by ocular. They have this gonio lens which don't have to be holded. It's like a contact lens. We can just put it on the cornea. So your two side ports are covered and only the main incision is exposed. And you just touch the gonioscope and you can get a good view. So for beginners, ideal way to learn is after every cataract surgery, you place the gonioscope, observe the angle structures in each and every case. Once you have mastered, then you can go ahead with your gonioscopy. Coming to the spatula, if spatula is not long enough, most of the time the spatula is not long enough, you can take a normal 24-gauge needle, bend it like a bang procedure, just place the needle inside, just go towards the TM, but never pierce it. You have to be very gentle in that. So, Shamira, thank you for the nice talk. It was very nice talk. The tips given by Dr. Tanuj and Devin, I'm sure is going to be helpful for all. So Now we go ahead with the next talk. And our next talk is by Dr. Swati Upadhyay. Just 1 minute, I'll just stop sharing the screen. Yeah, Swati.
Yeah.
So, Swati Upadhyay, basically, she is graduated from Jabalpur, India, and she has done her DNB from Arvinda Hospital, Pondicherry. She did a glaucoma fellowship from Arvinda Hospital, Pondicherry, and is actively involved in teaching and training. She won the Best Paper Award at GSI in 2019 and the Best Poster at GSI in 2021. Her keen interest in Migs and her movies of GAT has won awards at AGS, ASCRS, WGC in 2023. She has numerous publications to her name and is keen on innovations in glaucoma and training of young fellows. Dr. Swati was one who started the GAT procedure and popularized the GAT procedure in India. She was the first person to be trained by Dr. Devendra Grover and started the GAT in India. So over to you, Swati, your presentation on GAT and Bang.
Thank you, Amit, for bringing together such a beautiful webinar. And thank you, AIOS and Namrata ma'am, for giving me this opportunity. My humble pranam to all my seniors and my gurus. So I'm going to share my screen. So I'll be talking on perfecting GAT and Bang and managing its complications. I have no financial disclosures. So rather than me speaking, I would like to present our movie, which we presented in ASCRS, AGS, and WGC. And this covers almost all the aspects of GAT.
Gateway to safe suture GAT. Gonioscopy-assisted transluminal trabeculotomy, or GAT, is the brainchild of Dr. Devendra Grover and Ronald Fellman from Glaucoma Associates of Texas, Dallas. The surgery involves an ab interno canalization of Schlemm's canal and achieves 360 degrees of trabeculotomy. This procedure is conventionally done with an expensive illuminated microcatheter. Alternatively, in the developing world, one can do this procedure using a low-cost 5-0 Prolene suture. Like learning any other new procedure, learning suture GAT is also a challenge and requires practice and perseverance to master it. It is like learning martial arts in a Shaolin temple. Here are the must-have items for performing suture GAT. 5-0 Prolene suture, low-temperature cautery, direct Swan-Jacob gonio lens, high viscosity ophthalmic viscosurgical device, or OVD, like Helon GB, 25 gauge MVR blade, MSD forceps, McPherson's forceps. An ideal suture GAT surgery involves the blunting of the tip of a 5-0 Prolene suture using a low temperature cautery to make a small flange. Following this, the suture was introduced into the anterior chamber under OVD. A small 1 clock hour initial goniotomy is made in the trabecular meshwork using the 25 gauge MVR blade. And then the flange suture is introduced into Schlemm's canal using MSD forceps under Swan-Jacob gonio lens visualization. With gentle strokes, the Prolene suture is advanced into the canal till it appears from the opposite side, where it is grasped at the tip above the initial suture and brought to the center of the anterior chamber. Finally, using McPherson's forceps, the external suture is pulled out, achieving a 360 degree ab interno trabeculotomy. In this movie, we share some beginner's complications. And we will also focus on 6 important tips and tricks to avoid them with a simple A, B, C, D, E, F. A, angle visualization. Initial intraoperative gonioscopy can be practiced on routine cataract cases before initiating or after completing the surgery. Tilt the patient's head 30 to 35 degrees away from you and tilt the microscope 30 to 35 degrees towards you. Put a drop of OVD on top of the cornea and gently place the Swan-Jacob gonio lens over this drop. Adjust the microscope magnification, start from a lower magnification, and then slowly increase it using the microscope foot switch till you get a clear view of the angle structures. Initially, during intraoperative gonioscopy, one will have air bubbles in the anterior chamber or too much pressure over the eye while placing the gonio lens, which can result in folds over the cornea and failure to see the angle properly. It takes a few cases to master this technique to visualize the angle perfectly. It will also be good to routinely practice the foot switch of the operating microscope, as both hands get engaged while doing Migs, so finer adjustments need to be done using the microscope foot switch. B. Blunting of the suture tip to get an ideal flange. The tip of the 5O proline is blunted to form a small flange using low temperature cautery. This is to make it atraumatic and facilitate its smooth passage into Schlemm's canal. An important tip: keep the low temperature cautery a little ways away from the tip to get a just needed flange. If the cautery comes in direct contact with the suture tip, the flange gets too big for the size of the canal. This may result in difficult entry into the canal, excessive bleeding, or may even create a false passage. C. Check for correct passage. In addition to a perfect flanged tip, there is another way to ensure that the suture is in the canal and has not taken any other path. This is to perform an indirect gonioscopy on the table using a sterile single mirror gonioprism. The blue color of the proline suture helps in identifying its presence behind the trabecular meshwork, i.e. in Schlemm's canal. This will also give us an idea as to how many clock hours have been traversed and how many clock hours are still remaining. An important tip: the direction of the strokes should be circumferential rather than perpendicular to the goniotomy. What happens if a false passage is created inadvertently? The suture can go into the suprachoroidal space and cause a choroidal detachment, which can be managed conservatively with oral and topical steroids, and in most cases resolves within 15 days. D. Descemet's membrane detachment. A DM detachment can happen in the process of threading the suture into the canal using MSD forceps while regrasping the suture each time for advancement. The upper blade of the MSD forceps can touch the Descemet membrane, causing a localized detachment nasally. Tips to avoid this complication: 1. Keep the anterior chamber deep by filling it with OVD. 2. Work away from the cornea while opening the MSD forceps to grasp the suture. And 3. Avoid opening the MSD forceps fully. Open it just enough to grasp the suture. E. Experiencing resistance in the canal. As the proline suture passes through Schlemm's canal, resistance is experienced when it reaches 180 degrees, as it has to turn to the other side. It is an indirect sign that the suture has reached 180 degrees, but sometimes it doesn't proceed beyond this point. Tips in this situation: 1. Try twin site GAT, which means threading the suture in a clockwise direction rather than the initial counterclockwise direction. 2. Leave the suture at the site of resistance, then try to localize the suture using indirect gonioscopy on the table. If the suture has reached 270 degrees, then try to make a small goniotomy at that site and retrieve the suture by making a new paracentesis located 180 degrees opposite to the site last reached by the suture. F. For better canalization, avoid bleeding. Make all incisions on the clear cornea to avoid any bleed from the limbal vessels, as this can result in poor visualization. Tips to avoid reflex bleeding from Schlemm's canal while making the initial goniotomy: keep the patient's head above the heart level by lifting the head of the bed in a reverse Trendelenburg position. Also, pre-fill and pressurize the anterior chamber with high viscosity OVD. We are sure that by implementing these tips during the learning stages of suture GAT, one can achieve desirable results and also ensure a safe gateway to successful suture GAT.
I never would have suspected that the boy would develop so quickly.
Thank you.
So this was about suture GAT. I think we covered almost all the complications that I have faced in my learning phase and my patients doing patients after I have learned surgery from Dr. Davinder Grover. And every tip what Davinder has given me has helped me a lot, and I meticulously and religiously follow all the tips. So, oh, my screen is, why is it? I'm sorry. Yeah. So now I would just like to show a movie of Bang. So after doing a phaco and IOL implantation, I would like to put pilocarpine inside the anterior chamber to myose the pupil. This is a 25 gauge hypodermic needle, which I am bending towards the bevel, only the tip at 90 degrees so that it becomes like a KDB. So now this is a comparison of a KDB blade on the right-hand side and a Bang needle on the left-hand side, which you can see that this is a low-cost alternative to KDB for the developing world. Start with a lower magnification and then slowly zoom up to get a good and first view of the angle. Make sure how much angle is visible by tilting the lens on either side. Just go towards the superior side and the inferior side so that we get an idea as to how much we can tear the trabecular meshwork. Introduce the Bang needle. You have filled the anterior chamber with high molecular weight OVD. You can see the blood reflects in the Schlem's canal. And now I'm introducing the tip of the Bang needle into the trabecular meshwork or the Schlem's canal. And now I'm just gently going in a forward hand stroke. This is the cleft which we see, that is the posterior wall of Schlem's canal after the trabecular meshwork has been torn away. And then similar stroke in the backhand stroke. And then tilt the microscope towards the superior side so that you can have as much access to the angle as possible. Perform a good IA. And as Dr. Shamira had shown, you can sometimes take away or peel off this trabecular meshwork using a microforceps. And in the end, you can see a very nice, beautiful cleft. And that means you have opened up, you have taken away the resistance of around 4 clock hours. So what can go wrong in Bang? The bent tip has to be bent towards the bevel, unlike cystitome, which is bent opposite to the bevel. Sometimes you can do that, but then it will not have the cutting edges to tear away the trabecular meshwork. One has to be very careful while introducing in and bringing out the bent needle, as it can cause Descemet's membrane tear at the main incision. Enter with the sharp tip facing towards the side and not upwards or downwards to avoid DM detachment. Excessive bleeding from the Schlem's canal can be taken care by reverse Trendelenburg position and high molecular weight OVD. So keeping all these things or tips in mind, one can get very good results both in GAT and in Bang. For the beginners, we should start with Bang. Once we are comfortable positioning the lens onto the cornea, docking the lens, turning the patient's head away from you, then marking the 35 degrees on the microscope as told by Dr. Tanuj, then proper positioning as told by Dr. Shamira and everybody, that proper positioning is the first step to start any mix. Then start with Bang. After we have become comfortable with Bang, we can go on to KDB. And then the last is the most difficult one is the GAT, because it requires a lot of patience and lot of maneuvering and holdability. So unless our left hand is stable, we cannot think of doing a GAT. So these are all from my side. And I would like to end by saying that intelligence and capability are not enough. There must be the joy of doing something beautiful. Thank you so much.
Thank you, Swati, for demonstrating a very nice video on Bang and GAT. So got a couple of questions, and I would like to put this up to Dr. Ganesh and Dr. Ronnie. So coming to Dr. Ganesh, everybody is talking about high magnification for performing this mixed procedure. What is this ideal magnification? Because if you increase the magnification a lot, you lose your stereopsis. So according to you, what should be the ideal magnification to do these procedures? Ganesh, am I audible to you? Ronnie, you can.
Yeah, thank you.
Yeah.
Yeah, I think it depends on the scope which you're using. And we go even up to 0.9, 1.1 in the no financial interest here, but the Zeiss microscope, which we use. And of course, as you said, the field of view becomes very narrow. So there's a trade-off between the magnification which you use and the field of view which you like to see. And so that's something which is comfortable to you. So I'm a -5 myope. So, and I have a little bit of presbyopia also. So that also plays a role when you use the device. So there's no one size fits all for such a procedure, but it's something which you overcome by practice and continue to see. That's where intraoperative gonioscopy plays an important role.
So what we saw is whenever the beginners, they start doing gonioscopy, they start practicing intraoperative gonioscopy, they always try to visualize the angle with a very low magnification. And they feel comfortable, that they are able to visualize the angle structures. But when they start performing the procedure, that time you are doing it blindly. You need to do it under high magnification because you need to visualize what structure you are hitting. So that is very important. That's the reason I asked what is the ideal magnification. And Ganesh, again, what is the most common complication that you have encountered in this GAT and Bang procedures? But the most common.
I think two most common is, of course, excessive bleeding. And number 2 is not identifying the Schlemm's canal. So intraoperative gonioscopy is important, but preoperative planning is equally important. So you have to do the gonioscopy in the clinic, make sure that you identify the angles properly, you've selected the patient properly. There should be a nice, well-defined angle structure. Supposing the iris is inserted anteriorly, just at the scleral spur, that may not be a very good situation to do a angular mixed procedure. So all this planning has to be taken place right in the outpatient department, and then you go on to do it in the intraoperative situation. So bleeding and not able to identify the landmarks are two important things, and that's why you get a false passage also. And that's the third thing which you could come across.
Ronnie, I would like to ask you, what will be the ideal case selection for these procedures when one wants to start doing these procedures? And the ideal case, coming to the angle structures, visibility, mild and moderate glaucoma, we all talk MIGS works well with mild and moderate glaucoma, but now our indications have widened a lot. But what would be your choice for beginners, the ideal case situation?
If you're looking at a beginner who wants to do this, in my opinion, the best thing to do would be a pseudophakic mild to moderate glaucoma, maybe on a couple of drugs with a wide open angle on gonioscopy. And preferably not somebody who was a very high myope prior to the cataract surgery, because those eyes have a slightly lower globe rigidity and can be a little bit more challenging to do. So that's the ideal case to do it. I mean, if you're not getting a good pseudophakic case to do it, then somebody with a deep anterior chamber with cataract who's on a single combination is probably the best sort of patient to start with.
Yeah.
And reasonable pigmentation of the trabecular meshwork, because that helps you to identify the landmarks easily on your first few cases.
So ideally, we recommend that we do the cataract surgery first and then do this mixed procedure. But now quite a few of us are doing in the phakic eyes also this procedure. So first do the cataract surgery, so the angle structures are visualized nicely, and then you can perform this procedure. But as you mentioned, preoperatively, it has to be an open angle, and then only we should continue with this procedure. Again, coming to the most important contraindication, these procedures has reflux of blood. So, Dr. Sunita, I would like to ask you, what is the most important contraindication we should bear in mind when we are performing this procedure, taking bleeding into the consideration? I know the next
As you rightly said, I think these procedures can lead to bleeding. So I think the absolute contraindication for these procedures is neovascular glaucoma. And for the beginners, I would advise that even uveitic glaucoma and also a completely closed angle, the synechially closed angle should be the contraindication. So as we have discussed already for the beginners, I think the angle should be wide open, mild to moderate glaucomas. And if the angle is synechially closed, then I think it will be very difficult to identify the angle and even perform the procedure. But if you have performed PIN and the angle has opened up, then you can perform mixed procedure. And also, if there are intermittent PAS, then it is possible to do mix along with simultaneous goniosynechial
We have
disease.
a talk by Dr. Zurin on that. She'll talk about the latest advances in angle closure glaucoma. Zurin, I wanted to ask you, if most of the time we have these patients who are diabetic, hypertensive, cardiac, and they are on anticoagulants. Would you advocate Bang and GAT on patients who are taking treatment for this, who are on anticoagulants?
Yes, who are the hypertensive patient? Ideally, this hypertension should be well controlled. When we talk about the patient who are anticoagulant, we have to stop anticoagulant at least for 1 week prior to it. Then perform the surgery, and I think the rest of the 5 days post-operative period. I just want to add one point. You talk about the stereoscopy and the magnification. So most of the beginner, what they will do when they focus the angle and the high magnification, then while entering the instrument, we have to slow down the magnification, because when you enter into the high magnification, you can't enter into the anterior chamber. So come down to low magnification, enter into the anterior chamber, again go to the high magnification. These are the most common mistakes done by the beginners.
Ganesh, I wanted to ask you, Swati mentioned about the the cautery, that's a battery operated low frequency cautery. Now, most of our people don't have this cautery. What they have is the electric cautery or the ballpoint cautery. So how would they prepare the GAT suture, and what is the ideal gauge of the suture one should take?
Oh, the cautery, I know financial interest again here, but I'll just tell you the company called Bowie. We use their cautery. It's a very nice cautery, and it's ETOable also. So we sterilize it using the ETO. And the suture GAT, we use the 50 as well as the 60 proline. So depending on the structure of the angle, or for example, Dr. Rodney mentioned that pseudophakics, pseudophakics will have a slightly narrower Schlemm's canal than the normal phakic patients. So pseudophakics, we use a slightly smaller gauge suture, which is 60 proline. And for normal angles, we use a 50 proline. That's one. The second thing is, if you don't have a cautery, what you could do is you can heat your spatula using a lighter. That's
like
a trick which I learned from
something like a ballpoint
yeah,
cautery.
something like that. And then bring it close to the heat of the ballpoint cautery, and then bring it close to your, suture, and then you get a mushroom-shaped structure.
For bang, what is the ideal needle? Dr. Ronnie, can you suggest what is the ideal gauge of needle for the bang?
It's a 25 gauge needle, ideally. And I don't do too many bangs, but the ones that I've done with the 25. And that's, I think, exactly what Swati also recommends. Ganesh, you have a difference of opinion?
Yeah, some people are concerned that it doesn't reach the other side of the angle. So I'm very surprised at that. So, in some institutes, it doesn't reach, and some institutes it reaches. I'm very surprised.
No, so I'll tell you what, I do my bang procedure with the 24 gauge needle, because availability of a 25 gauge needle is very difficult. We don't get 25 gauge needle so easily. So the normal 24 gauge needle, which is available with the 2cc or 5cc syringe, I use that for the bang procedure, and I'm very comfortable with that. It reaches the opposite side also, and it gives you depend on where you are bending the tip. If you bend too posteriorly, then you have a wide tear. I mean, the opening in the TM is wide. But if you just bend the 0.5 mm of the tip, then you have the ideal stripping of the TM. So the gauge of the needle plays a very important role. I've seen some people use the 30 gauge insulin syringe, the needle, they pass the needle through the 26 gauge needle, they elongate the needle and then use it. But I feel the thinner the needle, you have the more resistance when you are doing the bang procedure and the needle gets bent. So even the needle should be of adequate resistance, because when you are doing the bang procedure, then there is resistance, and if your needle is too thin, the needle will get bent. So 25 or 24 gauge is ideal. Yeah, Swati, your input?
I just want to say 26 gauge needle which we use, it is very small. It doesn't reach the opposite angle, but 25 gauge needle nicely reaches the. So it's the orange color hub it has got. The 26 one has got a brown color hub. So if we have to aim for that, ask for that orange color 25 gauge needle, it will reach the opposite angle.
Yeah.
Thank you.
Thank you for your input. Now I go for my next presentation. I would like to introduce Dr. Sandra Seminski. Dr. Sandra, she is the Clinical Associate Professor, Director of Glaucoma Services, Vice Chair of Clinical Affairs, University at Buffalo, USA. She completed residency at Georgetown University and a glaucoma fellowship at New York Eye and Ear Infirmary. She received the Resident Teaching Award in 2012. She's been receiving the Buffalo Street Top Doctors Award continuously. She has also won the ICO Fellowship Award. Kevin, can you just mute yourself, please?
Did I ask you to?
Can you just mute the others? She's also done the Fellowship of Community-Based Research Award. She's the Resident Teaching Award at University of Buffalo. She's got multiple awards and she has co-authored numerous peer-reviewed publications and a special interest in laser therapy and glaucoma. She also serves the ophthalmology clerkship director for the University of Buffalo Jacob School of Medicine and is the chief service for ophthalmology at the Erie Country Medical Center. So over to you, Dr. Sandra. We would like to hear your talk, basically, which you selected on KDB, how to avoid the bleeding.
Thank you very much. Let me share my screen here.
Hyphema with KDB. This is very, very important. I didn't ask many questions on the hyphema part and the bleeding part because I'm quite sure you're going to cover all these things.
Yes, can you see my screen?
You are audible and visible also. Your screen is visible.
Wonderful, thank you. And thank you, Dr. Porwal, for this invitation. I'm so honored to speak at this webinar and be speaking amongst so many esteemed surgeons from across the world. So these are my financial disclosures, and some of them are pertinent to this talk. So I'd like to start with two patients that I had recently, and I think they're very unique patients because of the nature of the hyphema and their learning cases for me and my residents. So my first one's an 82-year-old male who came in for cataract evaluation and glaucoma suspect secondary to cupping. He has a history of cardiac stents, among other things that are pertinent to his case, but certainly is on Coumadin or warfarin, which is a blood thinner. And he has a high pressure and definitely cupping on exam, a little bit of field loss. And so we decided to do a cataract with Cahook dual blade goniotomy. So he had an uncomplicated surgery performed in the right eye. On his first day out, though, he presented with hand motion vision, a pressure of 33, and a centered PCIOL with a dense hyphema and a large clot in the nasal AC. And there was no evidence of iridosis, dialysis, cyclodialysis, or any traumatic presentation on his exam. So on his day 4, he still had a hand motion of vision of hand motion and a pressure 29. He still had a persistent nasal clot with a lot of cell and flare in his anterior chamber. We added Simbrinza just for pressure control and continued his prednisolone. And then you can see that the resolution of the hyphema took quite a while, and by day 15, the nasal clot was resolved. My second patient is also elderly white male with a cataract glaucoma evaluation and also with cardiac stents, and is on currently Plavix and Eliquis. And we go ahead and look at his exam. He has cupping, a nice wide angle, and again, some evidence of glaucomatous damage in his left eye. So left eye was done first, and he had no post-op hyphema and basically uncomplicated surgery. He undergoes the cataract surgery with KDB on the right eye, and he developed a microhyphema on post-op day 1. What's interesting about him is he actually improved to 20/20 and had a trace microhyphema on day 3, but then at week 1 presented with sudden painless decline in vision, 2200 vision, with a large hyphema and also some vitreous hemorrhage. He was seen by a retinal specialist and ruled out endophthalmitis or retinal detachment. With him, he actually slowly resolved as well, and by day 22, he did resolve his hyphema with basically conservative measures. So what do these patients have in common? They both underwent KDB goniotomy, which was uncomplicated, both had a long time to resolution, and both were on anticoagulants. So what questions do we need to consider, which are, what was the cause of these patients' post-op hyphema? Is anticoagulation a risk factor for developing post-op hyphemas? And how should Migs hyphema be prevented and managed? So as we can see, in the Migs space is quite large, and we'll be talking about KDB. But again, some of these points that I'll be talking about do definitely apply to other forms of Migs, particularly Bang. So we look at the angle anatomy, and we can see that we have 3 layers of the trabecular meshwork, which are going to be removed in KDB, opening up to the posterior wall of Schlemm's canal. And this goes on to the collector channels and the in the venous plexus. So a lot of this blood that we see in the hyphema involved with Migs is really just reflux from the venous system. So when we look at Cohook dual blade goniotomy, this is an ab interno Migs device with a dual blade to perform a smooth incision into Schlemm's canal. This blade lifts and stretches the TM to facilitate excision of diseased TM by parallel blades, which lifts and removes this TM. So I'm going to show you a couple videos that kind of demonstrate this is a cataract surgery combined with a phaco, and cataract surgery combined with KDB. And you can see here, as Dr. Pereira said in his talk, a juicy TM here, or a juicy angle where we can see the blood reflex. And I'm doing an inside out technique here. And what we can see at the end of this is just the TM strip here, which I'm actually demonstrating and leaving there for the sake of the video. And some people do advocate taking a microforceps and tearing this and removing it, but it can certainly be left in place without any harm to the patient or the pressure. This is another video by Dr. Paul Singh, again, demonstrating KDB. And again, you see the blood reflex. He's doing an outside in technique, so that strip can be amputated at the end of the surgery. And again, we see some blood reflex through the angle. And lastly here, this is an off-label use of the KDB performing goniosyncytial. And I'd like to point out that I'm using the heel of the KDB and not really engaging the blade because that can obviously lead to iris trauma and iridodialysis, which is unwanted and can obviously cause a lot of bleeding. So in terms of all the Migs, what are the rates of hyphema post-Migs? So hyphema is the most frequently encountered postoperative complication following Migs. And these are most often managed conservatively and they are self-resolved. And in some cases, hyphema may be anticipated as a sign of procedure success, given that the deroofing of Schlemm's canal exposes the collector channels to the AC. And we can see in this study here in 2022 that trabectome has the highest rate of Migs, followed by GAT. Highest rate of hyphema, followed by GAT and Cohook dual blade. So what's the pathophysiology of hyphema? So this is, again, blood reflex into the AC after disruption of Schlemm's canal. And this is more likely if Migs is done after phaco. So in this video to the right, you can see an eye stent being placed, and you can see the blood reflex in the original first stent when the second stent is placed. And many people do the Migs prior to phaco for this reason, but I do feel there is an advantage of doing the Migs after phaco because of the presence of blood that can actually highlight the correct placement of your Migs. Or traumatic bleeding from surgery, which is associated with procedures that tear through large sections of the TM, such as GAT. This can lead to larger hyphemas, IOP spikes, corneal blood staining, and potential vision loss. So what are the complications from hyphemas? Again, this is the same as a traumatic hyphema. You can have post-op IOP spikes, corneal blood staining, clot formation, surgical failure in the case of Migs, vision loss, and rarely a retrolenticular hyphema or hematoma. This can take months to resolve, and if treated with a capsulotomy, you can use a YAG laser, and the blood can dissipate into the vitreous, forming a vitreous hemorrhage. So what are some techniques to lower hyphema and lower the rate of hyphema incidence in Migs procedure? We've talked a lot already about the slight reverse Trendelenburg for patients with a high risk of increased episcleral venous pressure. Avoid tearing the TM strip. Again, you can tear the remainder TM strip in the case of KDB or Bang, but if you have a high-risk patient, such as somebody on anticoagulants, it's better to leave that in place. Avoid iris processes in your treatment. So if you do see iris processes and you do engage, they can bleed as well. So avoiding them is prudent. Use the heel only when performing goniosyncytial with KDB, and we showed a video of that. Pressurizing the eye with balanced salt solution at the end of the surgery to an IOP of 25 or more can alleviate the blood reflux. And with traumatic bleeding, you may need to tamponade with viscoelastic agent. So what about anticoagulation? This was already mentioned in some of the panel discussion. In a 2023 AGS survey of glaucoma specialists, they showed 48% had a high concern for performing excisional goniotomy, such as KDB, on patients who are unable to hold their anticoagulants or antiplatelets prior to surgery. However, there are few rigorous studies that have been performed to guide evidence-based perioperative care, specifically in ophthalmology. So how do we manage the post-op hyphema? Unlike the guidelines for traumatic hyphema, there are no formal treatment guidelines on Migs-associated post-operative hyphema management. Most post-operative hyphemas do resolve with conservative measures. Some will advocate a rapid lowering of IOP by an AC tap or wound burp, or with oral carbonic anhydrase inhibitors, but this can actually cause a rebleed, so that I would use caution with that. There was an interesting study that recently came out that looked at a retrospective analysis of 132 eyes undergoing KDB phaco to identify factors that influence success, and most importantly to this talk, predictive factors of post-op hyphema. And what they found was there was no difference in hyphema rate based on pre-op anticoagulation, which I found interesting. But the one factor that was a significant risk factor for post-op hyphema was a day one post-op IOP of less than 10 millimeters of mercury. So they suggested considering strategies to avoid hyphema in eyes with higher risk for postoperative hypotony, and discontinuation of anticoagulation may not be necessary before goniotomy. So in conclusion, hyphema after KDB is typically a self-limited event, and it does not impact surgical outcome. And there is no increased risk of hyphema associated with anticoagulation use before Migs, but if it can be stopped safely for a patient, as was mentioned a week before surgery, it is ideal to prevent a large hyphema, as I presented in the earlier patients. Intraoperatively, hyphema can be limited by pressurizing the eyes or tamponading with OVD, and also patient positioning. Post-op hypotony can increase the risk of hyphema, as demonstrated by the study that I presented. And thank you very much. I can answer any questions, and thank you again for the invitation.
Thank you, Dr. Sandra, for covering up the hyphema part very nicely and well in detail. I think we'll take up all the presentations first, and then we'll have a discussion. So without wasting much time, I request the speakers to be patient and be there in the webinar. So at the end of all the talks, we'll take up the question. So our next speaker is Dr. Jayant. Dr. Jayant Iyer, a very close friend and very closely associated with the All India AIOS. He's basically a medical director and senior consultant at the Straits Eye Center, Singapore, founding director at the Vision Mission Clinic, the Straits Eye Center, Singapore. He was formerly the founding lead of Singapore National Eye Center's Global Ophthalmology Division and head of its Clinical and Service Quality Department. He's done his fellowship at Johns Hopkins and has added subspecialist expertise in glaucoma. For his contribution to the fraternity globally, he has been conferred the APO Distinguished Service Award in 2021, the Novartis Excellence Vision Award in 2019, the Singapore Courage Fund Healthcare Humanity Award in 2020, and the Sing Health Service Star Award in 2022. He is passionate about eye care in the community and believes in forging strong links with the ophthalmology fraternity worldwide, so that more can be done in provision of equitable evidence-based eye care globally. So over to you, Dr. Jayant. Dr. Jayant is going to basically talk on stenting the angle. And thank you, Jayant, for being a key part, for playing a key role in selecting the speakers and conducting this webinar. Thank you a lot, and over to you, Jayant.
No, thank you, Amit, for organizing this. And I'm very glad to have played a small role in helping you select some of the speakers, many of whom happen to be very close friends. So it's an honor and privilege really for me to be spending time at such an esteemed, or rather to share the stage with such an august and esteemed bunch of panelists, including some of them are mentors, some of them my colleagues, some of them my fellows, even former fellows. So let's talk about stenting the angle. As you might have realized, I trained and currently do train some residents at Singapore National Eye Center. In Singapore, largely, Migs is, largely in terms of Migs, we kind of perform angle stenting procedures. That's our commonest, minimally invasive glaucoma surgery that we perform. So let me try to give context about Migs. Nothing, no financial disclosure of relevance. What is Migs? To kind of set context for things, Migs are a set of procedures as defined in Ike Ahmed's paper more than a decade ago as one that's supposed to have a high safety profile with low risk of sight-threatening complications. It's supposed to be one that supposedly minimally disrupts the ocular anatomy. As you have noticed over time, many Migs devices do disrupt the ocular anatomy, like these bleb-forming Migs like Zen and the PreserFlow. And it's supposed to have an ab internal micro-incisional approach, but many Migs over time have evolved to also have an ab external approach, like Zen and PreserFlow. It's supposed to be easy to use. That's not entirely true. There is a learning curve, and it's supposed to have meaningful IOP reduction. Previously, people used to make fun of Migs as MEGs, minimally effective glaucoma surgery, but I think over time, over the last decade, we have realized that there's indeed a good role that Migs can play in certain types of patients earlier upstream in terms of glaucoma management. So that criticism no longer is valid, I believe. There are various Migs strategies, and some of my colleagues on this panel also are involved in developing new novel Migs strategies compared to the ones that we see. So I'm going to be focusing on the trabecular bypass part of it, stenting the canal. So why Migs? Because, especially for the residents amongst us and the general ophthalmologists who are viewing this, I mean, we have been doing trabeculectomy now for over 50, 60 years, of course, with modifications, especially over the last 20 years with antimetabolites. But despite that, the complication rates, as many studies might show, like the TVT trial and many other studies, are unenviable, unfortunately, wherein it's in the rate of 30 to 40% in terms of bleb-associated complications, device-associated complications, post-operative related complication in terms of how the eye responds to these surgeries. So they are invasive procedures. They are not always predictable in outcome. And almost every trabeculectomy surgeon will say that, their rates are pretty good. But if you look at the prospective data, it may be slightly different. It's not as predictable as we would like, and not as high a success rate, certainly like cataract surgery. So much is left to be desired. Migs are promises to be less invasive, have less such complications, and advantages are then maybe combined cataract surgery, and it hopes to be more physiological when we are trying to resuscitate or make the currently available drainage systems of the eye a little bit more efficient. And really, the last decade has seen Migs trying to promise us reduced medication burden, which hopefully might improve ocular surface and quality of life in patients. However, as you can see, there are various Migs strategies. So whenever we have so many various ways to skin a cat or peel an orange for the vegans amongst us, you realize that there's no one perfect solution. So we haven't yet found the best Migs device, I would say. This is still work in progress, which makes us feel rather interesting. And as I've discussed before, some Migs are not necessarily less invasive, and some Migs that are thought to be quite safe over time have shown that they may not necessarily be safe, like the SidePass withdrawal from the market less than 5 years back showed. Let me now zoom in on the two devices I shall be talking about, which are the Hydrus and the iStent. Hydrus is a flexible, biocompatible 8 mm length microstent. It's supposed to stent up to 3 clock hours of the angle, and it's not just stents it also kind of opens it up a little bit. So it's supposed to really reduce the resistance in the trabecular outflow pathway. So it's like a scaffold and a bypass at the same time with significant span. So there were very, very good, I would say, gold standard trials that these guys have come up with. The Horizon trial, for example, that really assessed kind of set the standards and how we ought to be assessing Migs, perhaps. It kind of, the large amount of focus is on mild and moderate POAG, primary open angle glaucoma. They do include pseudo exfoliation and pigment dispersion, though. And they did a washout, and they kind of randomized patients to Hydrus versus phaco only. So one important point in these mixed trials is that we have found is that phacoemulsification alone in the context of mild to moderate open angle glaucoma may produce a significant and sustained IOP lowering effect, unlike what was previously thought 30 years ago. So having that as a control arm allowed us to really assess some mixed devices, especially if you are intending to do them together. So results have been basically, when you look at these patients, they largely choose patients who have mild to moderate glaucoma as you look at the visual field indices. And with medicated IOP, they tend to be around the mid-teens region, and the washout IOP tends to be in the mid-20s region. And what it showed in the primary endpoint of having more than 20% reduction in the washed-out IOP is that Hydrus had achieved a better outcome, which was statistically significant compared to just phaco alone at 24 months, as you can see. And also, more importantly, at 24 months, more than 3/4 of Hydrus patients were medication-free, as opposed to almost half of patients who were medication-free in the cataract surgery alone group. Of course, they stratified patients into those who had required 1, 2, or 3 medications for control prior to surgery. And of course, those who were just on 1 medicine, more of them had benefits compared to those who were on 3 medicines. And they also looked at the complication rates, which was really quite minimal. Largely, it involved transient hyphema or device malpositioning. Other than that, it was largely complication-free. So that is over up to 5 years, there was hardly any corneal edema. The CCT was okay. The endothelial cell count was fine as well. So largely complication-free. And even did the endothelial cell loss to compare it against the previous studies which showed significant endothelial cell loss in patients who had undergone CyPass, for example. So this is the Hydrus delivery system. If you all are able to see my screen, you can see a nice tracking wheel that will allow us to just to deploy the stent. And after we have engaged the trabecular meshwork, you employ the stent in such a manner. And it's a really, really quite a cool device. It's sits quite easily ergonomically, the fingertips. It does take a little bit of a learning curve, first 2-3 cases. Under good mentorship, you should be able to do it. And of course, as Dr. Shamira, my colleague from SNEC, had talked about in the first talk, having good visualization is of paramount importance. So mastering your intraoperative gonioscopy skills are of vital importance in being able to perform any minimally invasive angle surgery. So here you would typically do a sideport sort of blade to about 3 to 4 clock hours away from your incision, from where you want to deploy it. And typically you like to deploy the Hydrus microstent in the nasal quadrant where it has the most collector channels. Then you ensure you have positioned it correctly, have an on-fast view so that you can appropriately deploy it where it's supposed to go along the pigmented trabecular meshwork, the Schlemm's canal is. Ensure you have adequate viscoelastic device, put a Swan-Jacob lens or eye prism, whichever good gonioscopic device that gives you good magnification and good view. Fill the eye enough such that there's no stray and yet not too much so that you're able to see some blood reflux and some pigmentation. And once you've achieved that, with good gonioscopic visualization, you point it 15 degrees upwards, just at the top part of the pigmented trabecular meshwork. And once you've hit under the shoulder of it, you deploy it. And you're supposed to be able to see 3 windows. And voila, that's about it. The iStent Inject W, which is the latest version, and now they also have iStent Infinite, as Shamira alluded to earlier, is a very cool device. It's a heparin coated of porcine origin titanium stent, as opposed to the nitinol device that was Hydrus. That is the smallest device known to mankind, with an 80 micron diameter that sits within the Schlemm's canal and an outer inlet and flange that sits facing the anterior chamber with 80 micron diameter to allow the flow. The device comes with 2 preloaded iStent Inject Ws. Study recently showed a similar study that looked at in endpoints of patients looking at 20% reduction of unmedicated diurnal IOP and a mean reduction in IOP in over 500 patients, comparing phaco versus phaco iStent. And they found very similar results in terms of having better outcome in terms of 20% or more reduction in unmedicated IOP and having significant lowering of the mean unmedicated IOP. And if you notice, once again, the cataract surgery group alone also has reasonable IOP lowering effect on its own. And of course, of note, there are more people off medication in the iStent group. Also, there's hardly any significant complications, which largely involves stent obstruction, significant intraocular inflammation, most of which usually resolves. Very few patients require secondary glaucoma surgery, but remember, this is also to do with patient selection. You're choosing mild to moderate open angle glaucoma patients. So there are some real-world 5-year outcomes data. In this study, this is a case series, so you have to take it with a pinch of salt. Of course, here they did not differentiate between cataract alone versus cataract combined with eye stent. They lumped them together, and what they found was that significant IOP reductions that sustained in a mean of up to a 5-year mark. 69% reduction in also the need for medication usage in patients who underwent phaco eye stent or eye stent alone. Here's the first generation eye stent that we used to insert, I don't know, more than 7 years ago, I believe. After a good, in the Swan Jacob lens, where we're trying to have a good visualization of the angle. This is like a mini hydrus, I suppose, wherein we are injecting, or we are putting in this device. At the click, we're able to deploy it. And once you identify the pigmented trabecular meshwork, we kind of stent it, keeping our hands very, very steady and keeping it parallel in an on-fast view to the pigmented trabecular meshwork. Once we have made a mini kind of trabeculectomy there, then we deploy the device. And with a click, we just release it. And we do the next device. So that's how we deploy the eye stent inject, as eye stent first generation. Nowadays, we moved on to eye stent inject, which is done in this manner. So I typically do it after phacoemulsification. Some people do it prior to phacoemulsification. It doesn't matter. There are two schools of thought on this, but essentially the main ground rules still apply, having good viscoelastic deployment into the anterior chamber to keep it adequately filled in the late teens or early 20s, and then have adequate visualization with the eye prism gonioscopy in this case. Here you can see very, very nice visualization of the PTM. It comes preloaded with 2 eye stent inject devices. So once I've identified the PTM, I dimple it a little bit, and then once I get a nice dimple, I deploy it, and then you'll see some backflow of blood coming, so which tells you have achieved a good outcome in the right anatomical location. And you move 1 to 2 clock hours away, and you deploy the second stent in a similar fashion. Compare trial is a very good trial that looked at RCT comparing plain hydrus, not including cataract surgery, against plain eye stent, first generation. And it found that two of the first generation stents, it found that hydrus was statistically superior in lowering the medication count post-surgery, a 2-year mark, and IOP reduction. Some other retrospective studies that looked at real-world outcomes in combined cataract surgery and eye stent, and combined cataract surgery and hydrus, found comparable IOP reduction and perhaps slightly better medication reduction for the eye stent group. So the jury's out there. Overall, they have similar outcomes. But remember, not every day is Sunday, and I'm going to just show you 1 or 2 complications and how we can manage them intraoperatively. But I shall not steal the spotlight from Dr. Lo Jinrong, my colleague, who's speaking next on eye stent and hydrus-related complication. But here's a couple of them just to whet your appetite. So after we've done cataract surgery, in the same fashion, we kind of ensured we had good visualization of the trabecular meshwork. And I deployed the first stent. And this was done unremarkably, as you will see soon. In this case, you notice we could have had a better magnification than what is shown. And some of the visco actually came out due to pressure. And we wanted to get away with it very quickly and get a next eye stent injected. But that is not a good move. You can already see striae. And this eye stent was not properly deployed. And you can see a lot of visco coming out of the eye. So clearly the eye is becoming hypotenuse, not getting a good view. And the eye stent inject was not implanted appropriately. So I took over. We decided to fill up the eye with more viscoelastic device. And then we use the same device to try to recannulate and pick up the eye stent, which is a bit more challenging than you would think. So it took quite a few attempts to reorientate it properly. And once we managed to reorientate it and capture it back on the device, and I get a good view of the PTM, we puncture it a little bit, apply a little bit of pressure, and then deploy it. And now it sits beautifully with a nice backflow of blood. With regards to the hydrus as well, things can go wrong. Here's an example of a hydrus, which we tried to first deploy pre-cataract surgery. After getting a reasonable view, I apologize for the video quality on this one. We couldn't quite deploy it because there seemed to be an obstruction in the canal. So the hydrus wasn't quite getting optimally deployed, and it went posterior, and we couldn't see the 3 windows. It seemed to deploy posteriorly and inferiorly. So we decided to pull it out, re-inject it, reorientate it. But as you will notice, that didn't quite work out. I hope you're able to see my video, everyone. If you're not, Amit, please shout out. Excellent, thank you. So here we try to look at it again. It seemed okay. The visualization seemed all right, but it just would not go all the way through. There might have been some obstruction or orientation wasn't right. And trust me, this went on a few times. Apologies when it went out of the field of view of the camera, but it didn't really go in an optimal position. So we decided to complete the phaco in a dense cataract. Once we completed the phaco, put the lens in, we decided to try to give it a go again. It didn't work. So what we decided to do in the end, as you will notice, is we pulled out the hydrus device from the canal nasally. In this case, we couldn't use the device to pull it out, so I used the Kelman to pull it out, and we resighted it inferiorly because there might have just been an obstruction, anatomical obstruction there. So we did another wound, and we decided to inject the hydrus inferiorly, where we get a nice view, and we deploy in the same fashion that we discussed earlier, 15-degree sort of angulation at the pigmented trabecular meshwork. And once it's in, we kind of make it on fast, parallel to the trabecular meshwork. And here you can see, once again, pardon the view, but I think you can relatively see the 3 windows nicely opened up. And it's translucent, it's not shiny, it's well in the right location. And then we complete the rest of the surgery using IA. There are a few more, but in the interest of time, I will move along and summarize my thoughts. So basically, there are still many devices with numerous ongoing studies, but Migs has indeed filled in a good gap as a treatment option in earlier stages of open-angle glaucoma. In POAG mild to moderate, phaco itself has been shown to have an IOP lowering effect, but phaco Migs has an added benefit of reducing IOP and decreasing the need for post-operative glaucoma medication. So I feel that's a good role in itself in reducing medication burden, achieving target pressure in the mid-teens, and hopefully getting better quality of life for such patients. So I typically use iStent or Hydrus for isocataract and mild to moderate OAG or OHT requiring medications. I managed to reduce the medication burden in patients with 1 to 2 drops very well. I find that it does improve quality of life. Patients are very happy to not be using eye drops post-surgery, many of them a few years down the road. In more advanced patients with glaucoma who do not want trabeculectomy because they might have lost the other eye to that, I do use Migs as well, sometimes mainly to reduce medication burden with caveats. With that, I thank you very much. I'm happy for taking any questions at the end of the talk.
Thank you, Jayant, for covering up the iStent and Hydrus in detail. And now, please stay over. We'll go with the next presentation. And this will be by Dr. Loh Jin Rong. So Dr. Loh Jin Rong is a consultant in glaucoma department at Singapore National Eye Center. He's trained under the Sing Health Ophthalmology Residency Program and completed the SNEC Glaucoma Advanced Clinical Specialist Program in 2021. He's actively involved in undergraduate residency and optometry training in education. He received the National University of Singapore Junior Doctor Teaching Award in 2018, the SNEC Outstanding Educator Award, the Japanese Ophthalmological Society International Young Investigator Award, and the Sing Health Residency Outstanding Faculty Award in 2023. So over to you, Dr. Rong, and he's going to talk on how to manage complications of incisional goniotomies.
Thank you very much, Dr. Amit. I'll just share my screen. So indeed, I was a fellow of Dr. Jayant and Dr. Shamira, and I'm very grateful for their mentorship. I'd like to thank AIOS for the kind invitation. So I'll be speaking on complications of trabecular mix. These are my disclosures. So we know that mix target 2 main outflow pathways, the trabecular outflow as well as the suprachoroidal outflow. And for trabecular mix, it can be trabecular bypass or dilatation of Schlemm's canal or trabeculectomy. For the purpose of this talk, I'll be focusing on trabecular bypass. So complications of trabecular mix can be divided into intraoperative or postoperative. For intraoperation, there may be stent malposition or suture misplacement if using GAT, hyphema, DM, descended membrane tear, irido or cyclodialysis, and lens-related injuries. For postoperative complications, one may commonly encounter hyphema or eye pressure spikes due to stent obstruction or peripheral anterior synechial formation. Uncommonly, there may be cyclodialysis cleft leading to hypotony. As with any intraocular surgery, there may be complications of postoperative inflammation and infection. So I'll just move on to the first video. You can see this is a hydrous implant in the nasal angle. You can see that it is implanted too superficially and just grazing through the trabecular meshwork. So in such a scenario, it should be retrieved and reimplanted in the right position. Next, we have a video showing a hydrous implantation in the nasal angle. Initially, it seems to be going in quite well. However, later on further inspection, you can see that the distal end of the hydrous is sticking into the anterior chamber. So that is unstable and is being retrieved back and reimplanted in the inferior angle, and that went well. And next we see a hydrous implant in the nasal angle. Initially, it seems to be in the right position. Subsequently, it was noted to be diving downwards, hence it was removed due to the malposition. I'll just forward the video. An attempt was done to implant at the inferior angle. However, it was found that the TM was very scarred and stuck down, despite the eye not being overfilled. So the nasal angle was reattempted at a more distal site and resulted in a successful implantation, as you can see here. So next, there's a case of iridodialysis from the hydrous implant. This was during the time when patient seems to be moving. There was patient movement. I'll just forward the video. At this time, the surgeon could not get out in time, and there was an inadvertent posterior pressure that resulted in a localized area of iridodialysis, as well as hyphema. So after the blood was cleared out, reattempt implantation at a more distal site was performed, and the hydrous was implanted well in the Schanz canal. And sometimes there may be persistent hyphema that may result in high intraocular pressure, which may necessitate an anterior chamber washout of the hyphema. This is an interesting case similar to the one presented by Prof. Shamira, angle closure eye off-label use of the hydrous implant. So in this case, the hydrous was implanted in the inferior angle. As you can see here, it's going in well. However, there's a lot of pigmentation as well as some peripheral anterior synechial over that area. So after successful implantation of the hydrous, I used the similar tip of the hydrous delivery system to do a limited goniocytolysis. And that reviews the 3 windows of the hydrous implant. And this is an interesting case by a fellow. You can see here the surgeon attempted the implantation. However, you can see here that there was a sudden upward movement that resulted in a free trabecular meshwork flap or leaflet being created. She then went on to implant the hydrous at a more distal site. And that went well. You can see it tracking in to Schanz canal behind the trabecular meshwork. So in this case, it's important to do adequate irrigation and aspiration to remove the free TM flap. If not, it will cause occlusion of the inlet of the hydrus, causing IOP spike. And also injection of a full air fill in the anterior chamber to treat the DM tear. So these are some photos showing post-operative obstruction of the hydrus inlet. You can see the arrows pointing to the inlet, and that can cause high eye pressures. And in some cases, it may even cause retraction of the hydrus implant. So I'll just skip this part as it was gone through by Dr. Jayan previously. So I move on to a few iStent cases. This is iStent inject W with a larger flange. In this case, you can see after the first implantation, there was quite profuse bleeding hyphema. And sometimes this can obscure the visualization. And in such a scenario, I would do an adequate IA to clear the blood and re-inject cohesive viscoelastic and implant the second stent. And this went well. Soon during IA, you can see the two stents, which are about 2 clock hours apart, being well positioned. I just want to show this very nice fluid wave that's been created after the successful implantation of the iStent. Just focus on the nasal prominent epicleral vessel. You can see here, it is now being blanched and due to the fluid wave. There sometimes may be a sign that there's a good outflow from the implantation. One may also use tryptophan blue dye to clearly delineate the aqueous veins after implantation of any bypass stents. Next, we have a case of iStent Infinite. You can see here after implantation, there's also quite profuse bleeding. I just forward the video. And after clearing it, the blood away, you can see the iStent Infinite being well positioned. And this is a case of iStent Infinite as well, being under-implanted. You can see here in this case, there's a trocar bias in which during withdrawal of the delivery system, the trocar has tugged onto the iStent implant, causing it to be dislodged slightly and under-implanted. So I use the side of the introducer to nudge it in place. For the iStent inject as well as the iStent inject W, you may use the sleeve that's closed and use the tip to push it in. And this is an interesting case of iStent Infinite in which two stents were being ejected simultaneously. This can sometimes happen when the singulator is being depressed prior to the first stent implantation. So you can see here, with the click of the button, injector, two stents were being deployed beside each other. In this case, I use microforceps, intraocular forceps, to try to remove the malpositioned stent. And then I manually insert it to 2 clock hours away. One may also retread it, like what Dr. Jayan has shown, and re-inject it in place. This is a photo showing an iStent inject being blocked by iris post-operation, and it can also lead to high eye pressure. And very rarely, it may also lead to endophthalmitis as with any intraocular surgery. So these are the iStent complications. Next, I'll just show a few videos of cutting procedures of trabecular Migs. This is a KDB. And it was going fine. However, towards the distal side, apologies for the out of frame, one may notice that there's iridodylisis created. Yeah, sometimes due to the blood blocking the view and inadvertent posterior motion. And this can be repaired later on. Sometimes KDB may also result in post-op hyphema, as mentioned earlier on. In this case, it left a hyphema behind the intraocular lens, which later resolved. Very rarely, it may lead to cyclodialysis cleft and hypotony. KDB complications include eye pressure spikes, about 10% at week 1. Very rarely, about 2% may require additional surgery for uncontrolled eye pressure. And hyphema rates are about 17%. So GAT, as also mentioned earlier on, the most common complication is hyphema, up to about 50%. Most of them resolve spontaneously within 2 weeks. And these are photos showing the hyphema. In panel A, one may see the blood in the anterior chamber. And in B, it's also showing the blood behind the intraocular lens, which most of them clear with time. So in summary, it's important to recognize intra and post-operative complications from trabecular mix and manage them accordingly. Prevention is key, as what Prof. Shamira has mentioned. Clear on fast view, the right patient selection, identification of the angle landmarks, appropriate cohesive OVD use, and one may also use anti-glaucoma medications to prevent post-operative eye pressure spikes. Thank you very much.
Thank you, Dr. Ron. You have nicely covered all the complications of institutional mix. Now we go to our next talk, and our next talk is by none other than a young dynamic lady. Dr. Zillian, can you just stop the screen sharing for a minute?
Okay, you want me?
Yeah, just stop the screen sharing and let me introduce you first.
You want to introduce me?
Yeah.
Okay.
So Dr. Zhulin is basically a professor of ophthalmology at Zhongshan Ophthalmic Center, China. She is the top 100 most influential people in ophthalmology in the Ophthalmologist Power List 23 and 2014. Top 100 most influential people in ophthalmology in the Asia Pacific region. Top 50 expertising glaucoma worldwide in expertise. Fellow of the Academy of the Asia Pacific Professor of Ophthalmology. Board member of APGS, Asia Pacific Ocular Imaging Society, and International AI in Ophthalmological Society. She has won the Distinguished Service Award, the Achievement Award of APO, too many awards. She has published 186 articles, Site Index 5980 and H Index 44. She is self-authored few books also, and I have gone through one of her books. She is very good mixed surgeon, and she has come out with a classic book on mix, which has a QR code. You can just scan the QR code and view all her procedures. There are more than 250 surgeries in that book. She has published 10 books of translated version of the WGO Consensus Series and the Asia Pacific Glaucoma Guidelines. I have known Dr. Zhulin in past meetings where I met her, and she's a very dynamic glaucoma specialist who talks a lot on mix in developing nation, and she has talked about mix in angle closure glaucoma also. So over to you, Dr. Zhulin, for your talks on advancements of mix in PACG.
Okay, thank you, Amit. Let me share my screen. Let me share my screen first. Okay, good evening, everyone. Thank you, Professor Amit Powell, inviting me here. My name is Shuran Zhang, came from Zhongshan Ophthalmic Center, Guangzhou, China. I would like to discuss with you about future mix chains for PACG. I will present 9 minutes PPT and 3 minutes for video, totally 12 minutes. I don't have financial disclosure. PACG is a majority of our patients from Asia Pacific area. PACG's angle is narrow or closed. You will see part of the angle open or totally closed. This is even more beautiful structure you will see. For early stage of PACG without cataract, LPI or SPI will be performed. Why PEI will be performed with cataract? For advanced stage of PACG without cataract, trabeculectomy will be the first choice. With cataract, then combined surgery, there is a phaco trabeculectomy will be chosen. Trabeculectomy is effective but not ideal surgery because more complications, troublesome post-operative management, and long learning curve. Combined surgery is not ideal surgery too because of complicated procedure, longer time operation, and more complications. On the other hand, mix is always used in PACG and early or moderate stage. However, it can be used in PACG and advanced stage with growing evidence. Let's take ab internal trabeculectomy or goniotomy GT, for example, to discuss related issue. First, after GSL, you will see beautiful trabecular measure and scale spur is still there. More beautiful structures show you see after GSL beautiful trabecular measure and beautiful scale spur, and this one even more beautiful and beautiful too. Study have shown out that PI alone or with GSL can effectively treat early or moderate PACG because he can reopen the angle and enhance the aqueous humor outflow. However, it is insufficient for advanced stage since dysfunction of trabecular medulla and Stenting canal also found in PACG. Then Stenting canal surgery may bring additional effect. Growing evidence confirmed that PI plus GSL plus GT, in here I refer to 120-degree goniotomy, can effectively reduce IOP in PACG patients. This picture I show you how to do this new combination surgery. PI first, then under the gonio lens, you will see the angle totally close. And then GSL 120 degree and then 100 degree GT. This procedure is very simple, quick, and less complication. I will show you the video after the talk. In fact, there are several retrospective studies to show this new combination can effectively reduce IOP in PACG patients with different instruments. And my team has performed more than 1,000 cases and have published 1 year and 2 year surgical outcome. The result is great. You will see the mean reduction from 13 to 19. The decreased amplitude is 44 to 54% and has a good complete success rate and qualified success rate. Our non-inferior RCT to compare PI plus trabeculectomy versus PI plus GSL GT has been finished and will be published in Shun, and found that the result is great. The new combination is non-inferior to PI plus trabeculectomy. Why this new combination surgery can work well? Theoretically, PI can solve shallow anterior chamber, and the GSL can solve PAS, and GT can solve dysfunctional trabecular medulla. On the other hand, for advanced PACG without cataract, there's another new surgical combination, SPI plus GSL GT, that is SPI first, and then 120-degree GSL, and then 120-degree GT. The procedure is also simple, quick, and less complication. The same, we have half-year and 1 year surgical outcome already published. And also we have another non-inferiority RCT. We'll finish in this year in June. That is trabeculectomy versus SPI plus GSL plus GT. You will see the picture totally different. The same, why this new combination surgery can work well for advanced PACG without cataract. In fact, SPI can solve shallow anterior chamber too. The other two are the same as mentioned as above. So eventually, based on our studies, I hope we can bring new option and new innovation in PACG. The new surgical combination can replace the traditional one. That is, SPI plus GSL plus GT can replace the trabeculectomy. And PI plus GSL plus GT can replace the phaco trabeculectomy. Now let me clarify 3 small questions. First, which is better for different range goniotomy. Based on my team, 2 studies published in J glaucoma and AJO, and show that 120-degree GT with or without PI is enough for POAG. And for the, let me push this one. Okay, for the goniotomy, I think the palatal micro hood or needle you call bang are good for 120-degree, very easy, better than another instrument. Okay, let me go back. Okay, second, what is the indication? Well, let me tell you, there's no consensus or guideline so far, but I have my personal opinion. Only PAS more than 180 degree with IOP uncontrolled using 2 or more medication, we will recommend this new combination surgery. The third, another mix for PACG can work well by through PEI plus GSL, such as trabeculectomy, iStent, or even the SEN. So I will show you the video after my talk. I hope I could present more, but time is limited. But you can watch more than 100 surgical videos from my books through the website or through the YouTube. This is the channel. You can scan it. You can scan. Okay, so let me summarize. Migs can be used in PACG, and the future Migs trend for PACG for replacing PI plus trabeculectomy and trabeculectomy would be these 2 new combination surgery. Of course, this presentation only represents personal point of my view. So welcome to join the APAO in February, Bali, Indonesia, and the APGC in May, Manila, Philippines. So thank you very much. I will show you my videos, only 3 minutes. Okay. The first video is the PI plus GSL plus GT for the POAG. The PI first, you can finish 5 minutes. And then on the gonio lens, you will see this is the wide and open end, so easily to use. I'm using the TMH palatal micro hook. It's very easy to finish lens canal surgery, 120 degrees. So the procedure very simple, quick, and less complication. The second video is for the PACG, advanced PACG with cataract. The same video, the PI first too. So you will see the angle totally close. I'm using the phaco trap. Slightly press the iris, and then you will see the beautiful structure comes out. The white one is scleral spur, the pigment one is capillary mesh. So you will see the white one after the incision is the posterior wall of lens canal. So the surgery you see is very quick, simple, and less complication too. The last one is for advanced PACG without cataract. This kind of patient should be do the trabeculectomy. So I will use this new combination to replace the trabeculectomy. So this is a SPI in the supranasal position, and the supratemporal side to do the GSL and GT. See, really easy. You will see the beautiful structure again. This microcool is much better than the KDB. KDB is too big, and the band, the needle, I like it too, but it's a little bit sharp. Okay, the procedure very simple, quick, and less complication too. So thank you very much. Thank you.
Thank you, Dr. Julin. It was very nicely presented. Your videos were excellent. So we'll have a discussion at the end of this webinar. Now I go to my next speaker. Our next speaker is Dr. Jasper Wong. Dr. Jasper Wong is a director and consultant ophthalmologist, finest ophthalmic care. He's the honorary clinical assistant professor in University of Hong Kong, the adjunct assistant professor in mechanical engineering in University of Hong Kong, adjunct assistant professor in biomedical engineering, Polytechnic University of Hong Kong, honorary specialist, Grantham Hospital and Queen Mary Hospital. His major research interest includes minimally invasive glaucoma surgeries, novel glaucoma therapies, teleophthalmology, and application of artificial intelligence in ocular imaging. So over to you, Dr. Wong. You are muted, Dr. Wong.
Thank you very much for your kind invitation as well as the introduction. Let me share my screen first. Okay, I hope everyone can see my screen now.
Yeah, I can see.
Yeah, thank you. So, good evening, everyone. I'm going to talk a bit about changing concept in Migs. No related financial disclosure. I think this is our traditional glaucoma treatment ladder. So, for mild, moderate disease, we tend to do something less invasive, eye drops, SLT, and traditionally for more severe cases, we do trabeculectomy, GDD, or even PSCP for refractory glaucoma. And Migs happens like around 10 years ago that we coined this term, and there's different options, different surgical options to fill up the gap between somewhere between mild, moderate to very severe glaucoma, so that we have more weapons in our hand to help those people with relatively moderate glaucoma. And we coined the term back in 2014 when Ahmed and Shahab published this particular mixed terms. So there are 5 key features of this mix when we talk about mix 10 years ago. First is rapid recovery. We want something less like trabeculectomy that takes weeks or even months to have good recovery. And of course, we need to have good IOP reduction, and good safety profile means very safe. So because the traditional glaucoma surgeries tend to be more complicated, so easy to have complications like fat leak or scarring, or on the other hand, hypotony. So also at internal microincision was coined at that time. So back then 10 years ago, we talk about Migs, we talk about ab internal incision. We don't want any conjunctival opening, and of course minimally invasive or minimal trauma. So actually, before we have the term Migs, we already have Migs in the market. That's canaloplasty or even other like endocycle photocoagulation. Those were kind of Migs, but back then we still don't have a term for Migs. And those early Migs, usually they are like not really implant types. They're more like a traditional goniotomy using different tools like trabeculectomy that was like almost 20 years ago. In the mixed era, we are more aware on Migs because we have multiple different new implants. So first Hydrus, iStent, and then later we have other implants like Cypress, even iStent Supra, and later on even Sten, or the previous called Infocus, now is called Pressaflow. The traditional classical mixed application was according to the way we do the drainage. So we have a sham canal drainage with suprachoroidal drainage and even subconjunctival drainage. So namely the Hydrus and iStent for sham canal, iStent Supra and Cypress, which is already retracted from the market, suprachoroidal drainage, and even for Sten and Pressaflow, which is subconjunctival drainage. However, the question has always been there, especially for Infocus that Pressaflow now. Are they really truly mixed, because when we coin this term, we are talking about at internal incision. We are talking about no conjunctival dissection. But for then you can still call it really a mix, because it's really an internal implantation. Although some people do what we call factory procedure, which is injecting the stent from external. But most of people classical way do it still at internal, although the drain is conjunctival. But for pressure flow, if you look at pressure flow, you do need like conjunctival dissection, somewhat like GDD or even a trap. So this is the video where we talk about stent, because I think most of the speakers today actually talk about trabecular stent, trabecular Migs. So I've done around 100 stents so far. Well, I started doing it back in 2018 and starting some studies when I was still a full-time academic professor in Hong Kong U. This was one of the surgical video that I've done. Sorry, it's really quick. So we mark the conjunctiva and do some MMC injections conjunctivally. We make a small wound. It's already a pseudophakic patient, and we do this injector passing through at internal wound, and externally you can see the needle tip here, the injector tip under conjunctiva, and you slowly push in the stent, and then you need to very carefully retract the injector. And at the end, we have to check the stent, which has to be freely mobile and not engaged to any tenon. And then at the last of the surgery, we remove all the OVD inside. So this is the intraoperative photo, as you can just see now. And for post-op 1 week, you can already see the tube, the stent is in a very nicely placed in subconjunctival space without too much scarring. And you can see the outflow. Sorry for the quality, but it's already had a shallow but diffuse flap. And for the first week, it's still quite injected in the conjunctiva. For my practice, I usually do a subconjunctival antimetabolite injection postoperatively. It's usually on day 3 and day 5 to make sure that the scarring would not engage, the scarring tenon would not engage into the outflow, into the distal end of the stent. So at 1 month and 3 month post-op, you can already see that the conjunctiva looks pretty nicely, and you can see the freely mobile stent implant under the conjunctiva, under the very thin conjunctiva, and the flap that actually still formed. I actually did ASOC back in the study days, and you can see the stent implant is well placed at the angle. So when you look at pressure flow, that's what we have said. You actually need to have a pretty big. I would say that's actually too big. I think for this picture, it's not done by me. It's just an online photo. Usually we do it with almost 2 mm, and I think that's probably quite enough for pressure flow. But for someone, if you make such a large parectomy, then basically it's more like a GDD or a trabeculectomy. Back then, like 10 years ago, there is a period of time when expression is very popular, at least in our locality. And I think pressure flow is somewhat like, the concept is somewhat like expressed. It's like back then the term was called a glaucoma filtration device. So I think it's somewhat like this. It's not really the mixed concept that have a very small one, but I think pressure flow is just giving you an outflow implant that prevent the ostium from closing. So it resembles more like a mini version of hybrid GDD, or very small version of GDD, or like an express without a flap. So I think that's what we are seeing in pressure flow. And we actually compared, back in, I think the study started in 2019 when I was full-time working in Hong Kong U. We started the stent versus traps that we haven't published it yet because it takes quite some time to recruit cases. Because of the randomized control trial, the subjects are blinded from the group assignment. So when they need, they have a failed medical control for the IOP, then we recruit the patient to have either stent or trabeculectomy, which is 1-to-1 randomization, and patient was blinded. They don't know the group assignment until they finish the surgery. And yeah, we basically exclude all the secondary glaucoma or juvenile glaucoma. So this is one of the early results. We are having more than 1 year result now, but these are relatively early. So we have done 74 cases in this study. So 38 was randomized in trabeculectomy group, and 36 were the same group because of the dropout. And most of them are quite comparable. I would say most of them are POAG patients, and some of them are having CACG, uveitic, or MPG. So the mean age was around quite similar, 60-something-year-old, with the baseline IOP around around 22 to 25. And of course, some of them are having like IOP of 50 or 40, and some of them 19. But the minimal criteria was, of course, it would have to be more than 18 to be recruited in the study. So this is the result. So with at least 1 year follow-up, 62 patients with at least 1 year follow-up, and 30 of them was a stent and 32 was from trabeculectomy. You can see the mean IOP reduction was very significant for both of the groups. So for the trabeculectomy group, it's almost 40-something%. And actually, this is very good. And you can see the actually mean number of medications is 0.04. Basically, everyone had off medication. So most of them have complete success primarily. And for the stent group, the IOP reduction is very good, it's 30%, and the mean IOP for both of the groups are quite similar actually. But because of stent group, the baseline IOP was slightly lower, so the percentage seems to be statistically significantly worse than the trabeculectomy group. But sometimes it's almost we can because of the baseline. But the medication, the post-op medication for stent group is slightly more. So some of them are qualified. So in the old days, when we talk about Migs, we are really talking about like internal implantation. But because stent or more concerning is pressure flow, since they do not fall into the mixed category, we always say pressure flow as one of the mix. Now we are more tend to use the terms mix for those internal injection, especially those trabecular mix. So trabecular mix seems to be taking up most of the mix that we are referring to now. And the new coming term is what we call MIPS. So it's the minimally invasive flat-forming surgery. I think Dr. Ron has just mentioned in his slide as well. I think in the international, academic coma sector, we are more and more using terms MIPS for stent and for pressure flow, because they do not really fall into the original idea of mix. And indeed, during the XPT study, I met a lot of stent complications of post-op fluctuations that we need much more manipulation. And sometimes personally, I love trabeculectomy. I don't think trabeculectomy is that evil or that complication prone. Just that it takes some time to learn the learning curve is quite steep. And sometimes when I do the XPT study, I really feel that I'd more like do trabeculectomy more than stent, because if you have ever tried needling a stent, I can tell you it's very difficult. The needle usually doesn't work. But at least if the RP goes up for trabeculectomy, I can easily needle the patient, and I sometimes even needle in the subland. So especially for early trabeculectomy. And for stent, it's very difficult. Once it's scarred down, there's not much simple things you can do. And sometimes even if you open the conjunctiva to dissect the tenon again, when you close it, they still got scarred down. So sometimes it's very frustrating for stent. And I think for stent, one of the most important drawback is that the unpredictability. So sometimes you feel, okay, this conjunctiva was pretty good and the tenon is thin, it's probably going to success, but eventually it's scarred down. And for some, the very angry looking conjunctiva, very rare, they have been on PGA for 20 years, but still not successful. Sometimes it's really difficult to select the suitable cases. So the glaucoma treatment ladder, I would say the ladder is basically gone for me. I say now is in the past 10 years and the coming 5 to 10 years is really huge change of glaucoma management. Because now it's not just Migs, it's sometimes MIPS, as you can see in the study results. Then it's a MIPS. Versus trabeculectomy, sometimes I think the outcome, the IOP lowering outcome is actually quite comparable to trab. Versus what now we are calling makes the trabeculum makes is much more like the effect of like SLT or even like one or two eye drops. So I think Migs and MIPS are actually not for the same group of patients. They are more like for different types of different severity of patients. So for Migs, it's much more like those mild to moderate glaucoma with cataract. And for MIPS, it's more like those who actually need the drainage, or who actually need subconjunctival type of drainage. But some of the patients or even doctors, they don't want the trabeculectomy. They don't want they don't want to take the high risk. They don't want to be, having go in and out of the surgical theater for a few more times. Then they might be the suitable patient for MIPS, especially when their optic nerves still have quite some reserve, like they still have quite a good visual view, but their IOP is not controlling well. I think MIPS are very good for them. For those who have not much optic nerve reserve, like a very tiny little central vision island, I think they probably, if they fail the MIPS, they don't have much reserve to continue another trabeculectomy. Therefore, those patients are usually go for trabeculectomy, directly. Although there's of course, a risk of write out, but I think that's to be discussed with the patient. And I think everyone here are well aware that because of the light trial in the EGS guideline published a few years ago, and we already offering SLT as the first line treatment for all the PACG patients. Actually, before the Lancet study published in 2019, I think starting from 2015 or 16, I already started offering my patient SLT as the first line, although the guideline hadn't said that, because think about it logically. So why we are giving, how do we decide when to give what treatment? It's based on the risk and the benefit ratio. So SLT is very safe, it's very, very safe, and it's quite effective. And on the other hand, eye drops, many people putting 4 type of eye drops, and a lot of dry eyes, MGD, allergy, and they have poor compliance. So I think given the safety of SLT and the effectiveness of SLT, I think it's worthwhile going for first. And at the end, so 5 years later, the guideline just came out, and I was very happy. I think now is another changing time point in history that actually could be one of the first line treatment for newly diagnosed glaucoma. Actually, I've been offering Migs and primary treatment option for newly diagnosed glaucoma for the past 3-4 years already, especially for those more than age of 50, where they already have some level of cataract. For those with like high myopia, they really wanted to get rid of their glasses. Then that might be a one surgery kill, one stone kill 3 birds: the cataract, the refractive, and also the glaucoma. So actually, over the past 3-4 years of practice, I think if I talk to the patient, I think 50% of them would go for Migs as a primary treatment rather than SLT and eye drops, because eye drops you need to put in every day, dry eye. Sometimes I don't have time to put in, I'm very busy. And SLT people, actually, some of the people calculate the cost, because SLT sometimes you have to do it like every now and then, maybe 1 year, maybe even 9 months, 1 to 2 years. So they still have a cost if you do it like bilaterally. But for iStent combined phaco, they might feel that, okay, I do it once and for all. So the long-term resources that you need to put into treatment would be slightly less. So I personally, I believe that, maybe 5 or 10 years later, those mix with very good safety, very effective, and, a very long-term, treatment effect, then they might eventually become the first line as well. So this glaucoma treatment ladder is actually kind of blurred out. There's no longer a ladder, but they're spectrum. So we have a spectrum of different treatment for different patients with different needs. So that's my 2 cents. So from take-home message, so medical concept is widely accepted by doctors and patients, especially over the past 2-3 years. And much less that I think one of the best thing for trabecular mix is that you don't need to rely on the patient's compliance to medications, and they don't have those dry eyes MGDs. And the changing classification of all these implant surgery will become more mature, I think, in the coming 5 years. So we will have better classification, especially I think there are some new mix in the pipeline is still coming out. And the expanding use of mix could have more role, especially in those early glaucoma management, so that patient instead of glaucoma patient, instead of like having a hypertension, keep on putting antihypertensive, or they may just have like an implant to kill everything off. And I think iStent at the Gold Coast company still, I think we'll be launching the iDose, the drop implant as well. So I think the paradigm will shift quite drastically in the coming. That's it. Thank you very much for inviting me again.
Thank you, Dr. Jasper Wong. So we now have finished all our talks, and I know it's past midnight in Singapore, China, Hong Kong. So we'll try to finish up in 10 minutes by taking a few important questions. So I thank all my panelists. I would like to have quick comments from my panelists without repeating the same thing. So coming to the talk of Dr. Ziulin Zhang, she recommends phaco with GSL with goniotomy or surgical peripheral iotomy with GSL with goniotomy. So any of our panelists have any experience in this procedure, because this is a very evolving and a promising procedure which she has already published. So would like to know from the team in Arvind, SN, Ames, what is your say on this?
No, I think what Dr. Ziulin has presented very nicely, and I think once you are dealing with mild to moderate angle-closure glaucoma with cataract or even clear lenses, once you take out the lens, you can definitely do a gonioscopy and a bang or a micro hook to open up the TM. So that is very useful because you are in the eye and you are tackling both the obstruction at the level of the TM as well as you're taking out the lens. So I think it definitely we should add this on in the management of angle closure. The only thing is post-operatively sometimes the synechia redevelop. So it may be prudent to maybe for short term put the patient on pilocarpine so that the iris does not re-adhere to the area of the synechia. But I think it is a very good procedure. All of us must try. Definitely better than doing a phacotrabeculectomy.
Is anyone doing among the other panelists, is anyone doing this procedure?
Yeah, we used to do some in some cases. As sir told, that definitely we have to start in such cases. We have to start pilocarpine for a longer period of time. At least I keep the continued pilocarp for 2 to 3 months in such cases. Only problem with the advanced cases where the chronic synechias are there, especially advanced glaucoma. Really, our results are not very encouraging. So especially mild to moderate glaucoma, really the GSL plus phacoemulsion works well.
So what instrument
apart from Amit, apart from pilocarpine, I think a lot of steroids have to be used because these synechia, when you break them, they cause a lot of inflammation. So it can lead to inflammation in the post-operative period. And sometimes in some of these patients, there's a membrane. So if you try to break that membrane is tightly adherent to the iris and it can cause bleeding post-operatively. So I think you have to take care of all these factors in the post-operative.
High dose of steroids and pilocarpine for a longer duration of time prevent peripheral anthracynic. And I think this works well with the Bang and GAT procedure also, because if you don't give pilocarpine, the PAS occurrence is very high. Coming to goniosynostosis, I would like to know which instrument do you all use, because a few of our speakers showed the synostosis being performed with the Tenito hook, with the KDB. So ideally, I mean, I would use KDB once we constrict the pupil and then use the KDB. There's a lot of iris chafing because our pupils are heavily pigmented pupils. So Dr. Sandra also showed about how she did the goniosynostosis with the KDB shaft. So what is your take on that? The panelist? Anyone? Dr. Ronnie?
So when I'm doing a goniosynostosis, I tend to use a spatula because that's what I find easiest. And I prefer not to use a KDB because you can shaft the iris at that point in time.
I use TMH, the Tenito micro hook.
Tenito hook is not available in India, so you have the luxury of using that. Ganesh, what about you? What would you advise?
No, I use the spatula just like Dr. Ronnie said, and you
Even
could.
those, visco cannula with a high density visco.
Yeah, you could do that. You could use a visco dissection also. You can do. There's no harm, and any blunt instrument which can reach up to the angle, because you have a bent in the visco cannula, so you may not be able to reach it. So spatula is a much better instrument. That's what I used to.
How do you?
I used to be a proponent for goniosynicialisis, and I think Shamir also was presenting one of the videos that we had come up with together about the tap, the sweep, and the tweep technique on goniosynicialisis. And I think Rahat Hussain, one of the people speakers, had presented his paper on goniosynicialisis. The truth is, while it showed anatomical opening in chronic angle closure, it's very tough to see chronic angle closure, unless you know for a fact it's early PAS. It's sometimes very tough to see those thick PAS. Even if you have successfully done a GSL, a goniosynicialisis, using whichever technique. I use a cyclodialysis spatula, by the way. Some people use visco spatula. Some people actually use tweezers to pull mechanically. So there are various methods you might want to consider. They have found that those in chronic proper angle closure glaucoma, there is not a significant difference in visual and intraocular pressure related outcomes when you combine with goniosynicialisis. Therefore, to be honest, I think I have cut back on doing GSLs. I've stuck with doing phaco, and some people in Hong Kong have, Jasper might tell you, have proposed the wonderful benefits of just a plain phaco in such eyes. And we deal with 80% Chinese here in Singapore. We get a lot of angle closure, and I get by with very good just phaco emulsification procedure in these patients without having to do GSL, because sometimes it's very tough to do it. But sometimes if I see it, I just do it because I feel better. I'm not sure I'm getting, but I mean, wonderful presentation from Sulin Sang as well. I'll take those into consideration. Yeah.
Second thing was, how do you all manage the recurrent hyphemia? I mean, quite a few times, especially GAT, you get recurrent hyphemas. So KDB and GAT, the incidence of hyphema is quite high compared to Bang. So anyone of you all, Dr. Sunita?
Yeah, in KDB, I think maybe 15-20% of the patients get hyphema. And I think if the patient, we have a protocol of stopping anticoagulants at least a week before the procedures, but still, I think you have to keep the intraoperative, the pressure high at the end of the surgery. If there is
recurrent hyphema.
Yeah, okay. So recurrent hyphema, I think, as rightly mentioned by the speaker, that there is no point in draining the hyphema because it has a tendency to rebleed. So I think you have to have patience. You can start the patient on frequent steroids and then you stop pilocarpine. I think I keep the patient on homide or atropine, and the inflammation has to be less. So you have to contain the inflammation. You have to maintain the pressure. Sometimes with the hyphema, when it blocks the angle completely, there's a tendency of IOP spike. So you have to sometimes use anti-glaucoma. You have to use steroids and just keep patience. Over a period of time, I've seen most of the hyphemas, even if it is half chamber and even full chamber, they tend to resolve over a period of time. And if you have to drain, drain the hyphema, then you should wait at least for 2 weeks before you take up the patient for the hyphema drainage.
I usually particularly leave some OVD at the end of surgery to prevent it. I think it's quite useful because those would actually first, there's a tamponade effect, and secondly, they would shoot up the IOP a little bit to prevent early hypotony to induce the bleeding.
Actually, what happens is when we use the high density OVD to control the intraoperative bleeding, these blood clots get stuck to the angle, and then chances of PAs increase. So I think Arvind group also, and what I also do is we keep continuous irrigation on, so that the continuous irrigation through the bottle high bottle height gives a tamponating effect, and the blood goes on escaping, and the bleeding stops by itself. If you use a high density visco, you are coagulating the blood and pasting the blood against the incised angle. What do you think, Ganesh? Yeah, Ganesh, are you online? Devin?
Yeah. I leave about 40-50% of OVD in the anterior chamber. Yeah, I do that, especially when I do GAT or when I do canaloplasty. For both the procedures, I leave. And if the intraocular pressure is slightly high on the other day, I just burp the wound in the OPD. So the intraocular pressure drops about 20-30%, and that relieves the symptoms of the patients. So usually when you leave so much of OVD, patients really see well. There's not much of blood clots. The visual acuity is good. The intraocular pressure also, in almost 70-80% of the patients, it's low. It's not very high, even if you were to leave. And the main advantage of doing that is, if you were to do GAT, you would see bleeding coming from the rear of the iris rather than front of the. If you were to wash, you would observe the blood flow comes from the rear also. So you tamponade the iris against the crystalline lens or the PCIOL, and that prevents the blood from going posteriorly, and you don't see those bags filled with blood, which have been shown recently, which need YAG a little early.
So coming to Dr. Sandra's talk, she mentioned about the role of anticoagulants need not be stopped. But what we practice in India, I mean, all our panelists view, I mean, do you all stop the anticoagulants, or you all continue the anticoagulants before the Migs procedure? What is the take-home message?
So far, I've been not operating patients who have been taking anticoagulants. I don't do Migs for them. I do a canaloplasty for them. I found that to be much better. But now, after listening to so many people, and especially Dr. Sandra's talk, maybe we could take up patients who were taking anticoagulants. We could stop it for 5 days, and then we could do the Migs procedure. Recently, I had a patient who had called me about 3 months after the GAT procedure, and he had a bleed. So I just told him to wait it out and take vitamin C tablets, and it sort of resolved. So if you have a late bleed, you could manage it that way also.
Dr. Zulin, what about you in China? Do you all stop the anticoagulants? Dr. Zulin?
Ziulan, for you, question for you.
Do you stop the anticoagulants before performing any Migs procedure?
Sorry, I cannot catch your questions.
Do you stop anticoagulant drugs before performing any Migs procedure?
Oh, okay. I know. Can I have a comment for all of the questions together? Okay, I will do the 3 things. One thing for even though I cannot catch all of the questions and the comments, but I just feel like people very interesting to my surgery. The first one for the GSL, I think you guys like to use iris spatula. I think it's too rough, too big. Just try the phaco trap, the bigger one. Phaco trap, very smooth. Just slightly press the iris under the wall of the anterior chamber. That is a very, very, very easy way, okay? Seldom to make the bleeding. Okay, for the Stenting canal incision, you guys like to do the KDB and seems really use a lot, but I don't like KDB because it's too big, okay? Too big, and you cannot see very well when especially in the angle culture glaucoma. So try to use I talk about the TMH, the tactile microhole. Why? Because this one is the size just exactly the thick Stenting canal. So you can see when you're inside the trabecular meshwork and go into Stenting canal, you can see, just like I express my feelings, that you can see he's walking inside the Stenting canal. So this is a totally different feeling when you use the KDB. I think the band, the leader, even better than the KDB. So in my practice, either the TMH, either or the needles, the 25G or 26G is good enough. Okay. For the bleeding, 120-degree goniotomy seldom to have too much bleeding, because whenever you go inside clearly to see, go inside Stenting canal, and you put that trabecular measurer face to your chest, and this way you will not touch the posterior wall of Stenting canal, so you will not to make the bleeding. Okay, two things make the bleeding a lot is one, to pull off the iris root. The second is the directly go into touch the posterior wall of Stenting canal. That will cause a lot of bleeding. So in my practice, GATT 360-degree goniotomy will have a lot of the bleeding. 240-degree, there's a little bit, but the 110 degrees seldom have the bleeding. So for my clinical practice, anticoagulation drug, I just don't need to use it. Okay, after the surgery, if I have bleeding, then I add it to the patient, or I will not use it. Okay, so easy way. I hope you can invite me to your there to show the surgery, or even come to my place to see my patient. Okay, because I go to my whole country, all over the country, to show my surgery for the live surgery, to tell the people to accept this new combination surgery. Okay.
Thank you.
I don't
Thank you,
know
Dr.
I
William.
answered the question or not.
Yeah, we have a couple of questions from the audience here. So the most common question which a lot of people have asked is, what are the post-op medications in case of Bang and GAT? When to start and stop anti-glaucoma medications? So anyone of you can answer? Swati, what are the post-op medications in Bang and GAT, and when to start and stop anti-glaucoma medications? You're muted.
So we follow the same as for cataract surgery. Steroids tapering from 6, 5, 4, 3, 2, 1 over 1 week period, and antibiotic for 10 to 15 days. That's all. If there is hyphema, I prefer to give homide rather than pilocarpine, and it has worked wonders. And as I agree with Sunita ma'am, that because of hyphema, inflammation is there. So steroids and homide will take care of the inflammation.
So, antibiotic, steroid, tapering dose. So what about pilocarpine? Do you all give pilocarpine routinely, at least for a month or two, for all your patients after Bang and GAT to prevent PAS?
No, I don't.
Ganesh, Devin, Ronnie sir?
I use in all my PACG cases, irrespective of what kind of procedure I do. But definitely, if you're using the Bang and KDB in open angle glaucoma, I don't use pilocarpine much. And really about this anti-glaucoma medication, talk about the anti-glaucoma medication. Most of the cases, I don't use anti-glaucoma medication post-mix surgeries unless IP is too high. And you talk about the recurrence of hyphema. When you talk about the recurrence of hyphema, most of the people, once the hyphema is there, IP become high, they wash it, and again, what they will do, they start the anti-glaucoma medication, and that makes again your eye more hypertonous, and they lead to the bleeding. So that's a recurrence of bleeding is happening because you're making eye your hypertonous. So avoid using anti-glaucoma medication until unless glaucoma is very advanced. Then only use the anti-glaucoma medication. Otherwise, you can avoid it. And second part, sometimes we have to go through the systemic workup also, because certain patients really bleed twice, thrice. We have a case where we washed the AC wash for my colleagues. For 4 times, he washed the AC wash. Finally, we signed they had the bleeding disorder. So that also we have to keep in mind if we get the recurrence of the hyphema often.
We'll have a quick answers from everybody so that we can cover 7-8 questions. So can we leave air after GAT and Bang to stop the bleeding? This is the question put forward.
Yes, we can.
Okay. Which gonio lens? Okay, this is cover answer already. Now, which gonio lens is superior, disposable or autoclavable? Dr. Tanuj, what is your advice on this?
So I prefer the Swan Jacob lens.
So the autoclavable one.
Yeah.
Okay. So I differ in this. I have the suspension one, Vogue Swan Jacobs autoclavable, but I am more comfortable, I feel, with the contact lens type, the ocular self-retaining. So it all depends. I mean, you should try very different types of gonio lenses, and whichever works good in your hand, you should use that. So why in a study on mix, the devices are compared with cataract surgery? Is it an enough comparison to approve a device? This is a question put forward. Anybody?
Can you repeat the question, Amit?
Why in study on MIGS, the devices are compared with cataract surgery? Is
The
it
reason for
enough
that is,
comparison to approve a device? Jane, can you answer this?
yeah, the reason for that is basically that many of these MIGs is combined with cataract surgery, first of all. And, these are patients that we are looking for, if you noticed in many of these studies, mild to moderate open angle glaucoma, right? So they have done standalone. First of all, they have done standalone. But we have found out through many of these studies, actually, for example, Horizon trial, the Compass trial that looked at CyPass, that cataract surgery itself had a pressure lowering effect that was significant, not just in angle closure, by the way. This is an open angle glaucoma of about 4 to 5 points. Previously, in the studies in the 80s and 90s, it was thought to be 2 to 3 points lower. But recent studies in this patient population of open angle glaucoma show that phacoemulsification itself reduced the pressure of over 5 points in 2 years to up to 5 years sometimes. So they thought that comparing phacoemulsification against a combined procedure will show that whether the added mixed device or the mixed procedure actually was truly effective, or could we have just gotten away with a plain phaco. So that's the reason they do it, I believe.
Yeah, I would just like to comment on this. That earlier, all the mixed procedures were compared with combined cataract surgery, but now mixed procedures, especially in India, we are doing without cataract surgery also in the phakic eyes. So it all, I mean, we are waiting for the long-term results of mixed in phakic eyes. Coming to the last question, and then we wind up. Ganesh or Deven, anyone of you all can answer, Dr. Tanuj. Other than the mild and moderate glaucoma and open angle glaucoma, what are the other indications that you would like to go for mixed procedure? I mean, the Bang and the GAT procedures. What are your other indications other than the mild and moderate open angle glaucoma?
I would say I would say we use it for like silicon oil induced glaucomas, silicon oil induced open angle glaucomas, could use for steroid induced glaucomas, and the other variety of open angle glaucomas, which is quite useful when you want to plan for the mixed procedures. So we've been using such indications as well.
Okay,
So I have also used in a lot of patients with secondary glaucomas where the glaucoma is not very long standing, pressures are very high, like post silicone oil, steroid induced, and other types of secondary glaucoma. So I think it's a good indication.
Even
Not just primary, but secondary glaucomas also. Yeah.
I've been doing Bang in post failed trab also, and it gives good result. So instead of doing a bleb needling, if you want, you can go ahead with a Bang procedure in failed traps, and you get a successful result. Dr. Jasper, you had something to say.
Yeah, I think GAT is worked beautifully, especially in failed traps. Apart from that, we have the number of the cases where this AGB and RD got failed. We have done the nice GAT, and we can't make the drop free, but really we can reduce the 70 to 80% of the drops we can reduce by doing the GAT. I don't sure about the Bang, because Bang I feel really less efficacy compared to GAT. If you're able to perform such as 360-degree GAT, really results are very beautiful.
Thank you, Deven. Dr. Jasper, you were commenting on something?
No, I'm just about to say that for the trabecular mix, I basically do for everyone with high IOP control. I think they are quite minimally invasive and the risk is really minimal. I think the only thing that in the head is the cost, right? And for MIPS, for SEN, especially for SEN, I think it's quite comparable to all the trabeculectomy. So basically, even I had the patient even have NVG and regressed NVG, of course, and they still perform really, really well. So I think basically the indication is same for trabeculectomy.
Thank you. So now we conclude this webinar. Before I conclude, I would just like to inform all of you all that we have more than 1,600 people live watching our webinar on Mix. That is a great number. And I thank all my panelists and our international speakers and our national speaker for making this webinar successful. I thank my president, Dr. Harbansh Lal, my chairman, scientific committee of AIOS, Dr. Namrata Sharma, and my whole team of scientific committee members who are behind this successful webinar. So I once again thank from the bottom of my heart especially for our speakers from China, Hong Kong, Singapore, who have stayed awake past midnight and are still part of this webinar and have continued throughout. Thanks a lot to our panelists also, and see you all. Bye-bye. Good night.
Good night.
Right.
Thank